Can you hear me? Thank you, everybody, for coming. My name is Sandy Cassanelli. I am the founder of Breast Friends Fund. Breast Friends Fund was founded by our family when I was diagnosed with metastatic breast cancer almost 10 years ago. As you know, most organizations, breast cancer organizations, give about 7 to 10% to the cure. So we decided we were going to start our own, and we give 100% to metastatic breast cancer research at Yale Cancer Center under the director of Dr. Eric Weiner and his team. And year to date, we've raised over $1.5 million. And living with metastatic breast cancer, I thought it was really important for us to make patients and their caregivers aware of new treatments and what's going on and important things that we want to discuss. So this is our second annual conference, and you know, we're at capacity, which is awesome, and hopefully we get bigger and bigger. So I wanted to introduce Dr. Eric Weiner, who is the director of Yale Cancer Center, president and physician-in-chief of Smilow Cancer Center, my doc, and my partner in fundraising and research. So.
Thank you, Sandy. Sandy's sort of amazing for those of you who don't know Sandy. Like, not only does she defy all odds all the time in everything she does, but she's done this huge fundraising effort, and it's sort of incredible. I actually first met Sandy at when I was at Dana-Farber, and she used to come up there. And when I told my patients that I was leaving and coming down to Yale, she said, "Oh, that's great, because it's much closer to me and I'm ready to make a change anyway." So thank you all for coming. I could tell when I pulled into the parking lot that there was sort of record attendance, because I've never had to park over by the electric vehicle parking. And it's sort of amazing that so many people are here. So thank you very much. I'm going to keep my comments quite brief. Living with metastatic breast cancer is obviously not easy. I can't speak to the experience myself. I haven't been there, but I've been doing this kind of work for, I'm sort of shocked to say, for over 30 years. And during that time, treatment has, of course, evolved tremendously. In 1990, we had 2 hormonal drugs. Now we have a handful. We had very limited chemotherapy, and it was all fairly horrific chemotherapy. And patients would be sick much of the time. They were either in the hospital or in the clinic, and we just didn't do a great job. And you know what has happened, of course, over the past 30 plus years is there's been a greater understanding of breast cancer, so that we now understand that breast cancer isn't one disease, but it's a family of diseases with very different treatment approaches for different family members. And we've developed new and targeted therapies that are much better. That said, it's far from perfect, and we have a lot of work to do. And it's one thing to say that we can help people live much longer lives and live much better lives. But it would be another thing to say that we could routinely cure everyone. And that's something, of course, that we, as I think all of you know, we're not there. Which is why it's so challenging for those of you who are sitting here and have metastatic breast cancer. And it's why it's our job to partner with you. And when I was fortunate to give a talk a couple of years ago at one of our professional societies, the title of my talk was Partnering with Patients, the Cornerstone of Clinical Care and Clinical Research. And I think we all embrace the idea that it's a partnership. And, you know, we're not telling people what to do, we're guiding them, and we're there for them. And, I think in an era when medicine has changed a lot, and how many of you have trouble finding a primary care doctor and getting through to your primary care doctor? And I hope some of you don't, but it's an increasing challenge. I think that oncologists feel more compelled than ever before to truly reach out to patients, and I have to recognize their families and their friends to really work together. And by working together, I think we help take better care of people. And when we do research, we answer questions to make care better in the future. So, and finally, looking over at my colleague, Tracy Battaglia, who I managed somehow to recruit to Yale from Boston about a year ago, it reminds me to say, and Tracy's work is focused on disparities in breast cancer care and how we're going to try to minimize those disparities. I just have to end by saying that one of our commitments is making sure that the great care that we believe we provide is accessible to everyone and not just to a select few. And it's just so very, very critical. So with that, I'm going to say have a great day. I'm going to be hanging out here for most of the morning, actually, until I have to go to an acupuncture appointment at 12:30, but I will be here. And you have an array of fantastic speakers. The one last comment I just want to make is that you will hear things at times in much the same way that it happens when you go to the internet that may disturb you a little bit, because you'll hear one of us talking about some result that surprises you. And I just want to caution you to sort of not react too much to medical information that you're hearing from experts, but who are not necessarily your doctor. And I think mornings like this can be really uplifting, but I think occasionally for people, they walk away and feel like, oh, I didn't know that. And just be careful about that, in the same way that I tell all the people I take care of to be very careful about going on the internet and looking up too much information, particularly at 3 a.m. when there's no one to talk to. So really have a really fantastic morning and early afternoon, and give us feedback, because we want to do better next year. And I know that, Sandy, who is behind all of this and cares passionately about it, and everyone else will be very interested in hearing what you have to say. So thank you.
All right, good morning. I'm Mariya, Chief of Breast Oncology, and really lucky to work with all of this wonderful crew that you're going to meet or have met already. So really happy that we're hosting the second conference. Before I explain the next part of the program, I just wanted to formally thank Sandy Cassanelli, because I don't know where to start, but really from the time that last year's conference ended, she was already emailing me about how we could make this year's conference even bigger and better. So she really works tirelessly, and a serious illness can make you look very much inward or outward or both. And Sandy does an exceptional job doing both. And she has given back so much to the community and really gone beyond herself. So just want to have a round of applause for Sandy. I also wanted to thank all of you for being here. I know life is so busy, and to take even a Saturday to come join us and really build this community where we can share ideas and learn from each other and be uplifted. So thank you to all of you for being here. I wanted to thank my colleagues, because their life is busy too, and it just takes a lot. And the reason we're all here is that we believe that we can exchange ideas and do a better job of how we communicate and take care of you. And you're our priority, so thank you for that. And I wanted to also formally thank all our sponsors because they have also helped make this conference possible. So thank you. One of the things that we learned from last year's conference, which was wonderful, was that sitting through breast cancer is not one type of cancer, as you all know. And so sitting through multiple lectures of scientific talks on a cancer type that may not be yours, we thought may not be the best use of learning time. So one thing we did differently this year is that we'll have 3 smaller groups where based on your type of breast cancer, you can break out and be able to interact and learn from a breast cancer expert specifically to your type of breast cancer. So this is one of the changes we made this year. And so this is going to be the next portion of our program. Now, if you're not completely clear what subtype of breast cancer you have, feel free to come up to me and I'll help direct you. The largest group would be the hormone receptor positive. Another name for it would be estrogen receptor positive, metastatic breast cancer group. That's generally HER2 negative. So you guys can stay here. Dr. Mariya Rozenblit will further introduce herself to you, but she's one of our breast experts who's doing a lot of amazing innovative research in hormone receptor positive breast cancer. If you have triple negative breast cancer, another name for it would be hormone receptor negative, HER2 negative breast cancer. You'll be in the conference room out of this room. So you'll exit this room you will have the opportunity to meet with one of our other breast experts, Dr. Sarah Schellhorn, who also delivered this talk last year, and she'll be able to kind of personally interact with you and answer your questions. And if you have a HER2 positive breast cancer, this may be hormone receptor positive or HER2 negative, but if you've been receiving treatments for HER2-driven targeted therapies, you'll go actually downstairs and you'll have the opportunity to meet Dr. Lajos Pusztai, who is one of our international breast experts in this area. So we'll give you some minutes to kind of get your things together and kind of direct you to these 3 different areas. And then we'll reconvene again as a group and talk more about some innovative clinical trials within the breast program. Thank you so much. Oh, thank you. Creates a lot of confusion. Oh, wonderful. Okay. Yeah. Oh, there we go.
sure to speak into the mic just so everything gets heard and gets caught on the Zoom or recording.
Got it.
Are you going to be looking to possibly take questions from people?
Yes.
Remind them to speak into their mics as well. It's what they're going to see if they press that button.
Okay.
This, they'll notice that nothing really happens, like this will get them.
Okay.
So you can just tell them the right button on the microphone.
Right button on the microphone. Okay.
They're also not crouching. We could move them to bring it close to them just because it makes it easy.
Should I start? Does anybody want to move a little closer? There's lots of seats up front. Okay. All right, it looks like people are settled. So I tried to keep this talk basic and short to leave lots of room for questions at the end. So please feel free to jump in if I'm not giving enough detail or if you want more detail. This is very interactive. And then I was told that if you have questions to please use the microphones for the people that are on Zoom and just press the button on the right side to turn it on to talk. Okay, so we're here to talk about hormone positive metastatic breast cancer today. And I wanted to start off by giving a little bit of background on what is hormone positive breast cancer. So when we look at these cancer cells, we're looking at receptors on the outside of the cell, and they're going to have receptors for the estrogen receptor and the progesterone receptor. And this is just a simple drawing to kind of help you imagine that. And what we do in the pathology department is when we get a piece of the breast tumor, we're actually able to stain it in a way that helps us see exactly how many receptors on average we're seeing. And we'll go over that. What does that look like in your pathology report that you might have seen in your chart? And then HER2 is also something that we test for, and it's a different type of receptor that's on the cancer cell that's more of kind of a growth factor. And when we talk about hormone positive breast cancer, these are tumors that tested negative for HER2. So they either had very little staining or zero staining, sometimes you'll see on the report. And we'll talk about how that's changing a little bit now. So this is just an example of what your pathology report might look like. So what does this mean in case you wanted to look in your chart? The first thing that we list in the pathology report is what type of breast cancer it is. So the word invasive basically means cancer, and it means that the cancer cells have learned how to leave the ducts and invade other areas around. And then we have two types. We have lobular and ductal, and that just explains where the cancer started from. So cancer can either start in the ducts or in the lobules, which actually make milk in the breast tissue. And then it will give you the receptor types. So the estrogen receptor, it will say positive or negative, and then it will give a percentage. And that percentage is when the pathologist looks at the slides, they're estimating how many of those cells were staining positive. And this is helpful for us as oncologists because we think of tumors as either strongly positive for estrogen receptors or maybe low positive. So most of the time, it's reported as 90% or above 90%, and that's what we would consider a strongly positive tumor. Sometimes if it says something like 5% or 10%,
we are now beginning to understand that even though those are technically considered hormone positive or estrogen receptor positive breast cancers, they act very differently. And when the estrogen positivity is very low, we're beginning to think that they act a little bit more like triple negative breast cancers and can be more aggressive. And sometimes we get a little bit more creative with what treatments we offer to those patients. The progesterone receptor is a little bit less important in terms of what treatments we offer. We tend to kind of lump estrogen and progesterone receptor positivity together because they're often both positive and they act in the same pathway that's driving the tumor. Sometimes if the progesterone receptor is low positive or negative, sometimes that can suggest that it might be a little bit more of an aggressive tumor type, but doesn't really change what treatment we would offer somebody. And then we look at HER2. HER2 is different than estrogen receptor positivity in the sense that we have two different tests that we do. So in addition to staining, which we call immunohistochemistry, we also do an additional test called FISH. And HER2 can get a little bit complicated because in general, 0 and +1, which means that there was very little staining, was considered negative. +2 means that there's some staining and we're not sure if it's positive or not. So then we look at the FISH test, which will give you a ratio and a copy number. But if you scroll all the way down to the pathology report, it will tell you if it's positive or not. And then +3 staining means that there was a lot of staining. And so we consider that positive. And most of the time we don't have to do this extra FISH test. I bring this up, and I'm sure this will be talked about in the HER2 group, but we have now new medications that are so good at targeting the HER2 receptor that they can bind even when there's very little staining. And so patients who were previously considered to have hormone receptor HER2 negative breast cancer, so if you had at least a little bit of staining +1 HER2, we're now kind of redefining that as HER2 low. And so some of those tumors might actually be responsive to some of the new HER2 treatments that we have out there. So just something to be aware of. And then Ki-67 is a marker that can be helpful to see how quickly cells are dividing. And so it can sometimes be a marker of aggressiveness in the tumor type. Honestly, Ki-67 is very difficult to stain. A lot of pathologists hate it because they feel like the variability is very high. So a lot of times it's not even reported in the pathology report. And a lot of times it's not going to change treatment, but you might see it there. And that's what it's suggesting, that it might be a faster dividing tumor. Okay, so what does metastatic means? Metastatic means that there were breast cancer cells that have now left the breast and moved on and have grown in other parts of the body. Unlike other cancer types, if it's moved just into the lymph nodes in the armpit, we don't actually consider that metastatic, even though it might say that in your pathology report. If it's only in the lymph nodes on the same side in the armpit as the breast cancer, that's often still early stage breast cancer. Stage 4, we think about as either moving to the other side or really distant areas like other organs like the liver and the bone. Bone is one of the most common places for hormone positive breast cancer to go to. So we'll often see lots of patients with bone lesions. Liver and lung are kind of the second most common places for breast cancer to go to. A lot of times there are no symptoms. And we don't have, unfortunately, good screening tests for finding metastatic breast cancer. So oftentimes this is accidentally found when somebody develops a new symptom, perhaps pain that's not getting better, that's not going away. Maybe they got a scan for another reason and it was accidentally found on a scan. So unfortunately, it's very difficult to find metastatic breast cancer. And by the time patients come to us, they often have several lesions and it's often spread to several parts of the body. And so our goal of therapy is to really make sure to prolong life, to make sure that patients can live for a long time with our treatments. and at the same time, not make the treatments too toxic. So we're really trying to focus in this field and how can we make these medications more bearable without interfering with your life too much. Because unfortunately, once the cancer has spread outside of the breast, if it's in other organs, we're not able to cure this type of breast cancer, but we can keep it from growing and hopefully extending to other parts of the body for a long period of time. So our first line treatment for hormone positive breast cancer is oral therapy, which is kind of nice. And we often do a combination of different pills. The main pill that we have in this category is something called a CDK4/6 inhibitor. And we combine it with an estrogen receptor blocker. And what we use for estrogen blocking therapy depends a little bit on the menopausal status. So that will be one of the questions that the doctors will ask. Where are you in your menopause status? How long ago was menopause? When was your last period? For women that have not gone through menopause yet, we often add a medication like an injection to inhibit the ovaries and put women into early menopause, because in hormone positive breast cancer, it's really the estrogen that's circulating in the body that's driving tumor growth. So we're trying to decrease those estrogen levels as much as possible. For our postmenopausal women, we don't need to do ovarian suppression, so they don't need the injection. And we can often start with a pill called an aromatase inhibitor. And the reason why we do aromatase inhibitors is because after menopause, our ovaries don't make estrogen anymore, but our fat cells in our adrenal glands make estrogen. And that's where those inhibitors target. They go to those cells and decrease estrogen production. CDK4/6 inhibitors work by inhibiting tumor growth or cell growth. So in order for a cell to divide, it needs certain enzymes, and this inhibits an enzyme called CDK4 and 6, which is important for that cell cycle. So what are the common side effects of these treatments? Because we're lowering estrogen levels, a lot of the side effects have to do with kind of postmenopausal symptoms. So a lot of these medications, especially the aromatase inhibitors, we see hot flashes, we see joint pain. A lot of patients describe kind of like a mental fogginess from these medications. It can thin hair a little bit. And of course, it can affect bone density, and we'll talk a little bit more about that. The CDK4/6 inhibitors, because they're inhibiting cell growth and they're not 100% accurate and don't just target cancer cells, one of the most common side effects is that it will affect other cells in the body, particularly the white blood cells, which are one of our fast dividing cells in the body. So we do have to check blood work pretty frequently when we first start somebody on a CDK4/6 inhibitor, and we're looking for something called neutropenia, which is the white blood cell numbers, and we adjust the dose based on that level. So if the white count or the neutrophil count is too low, we have to lower the dose of the CDK4/6 inhibitor. They do cause tiredness overall. There can be some decrease in appetite. We also look for more rare side effects. It can affect liver function very rarely, so we always check liver function as well. And once the blood work looks better and is stable, we can often space out the blood work so patients don't have to come in as often. Lowering estrogen levels can affect bone density. And a lot of times, like we talked about, in hormone positive metastatic breast cancer, there could already be cancer in the bones. So one of the standard treatments that we've started adding is something called Zometa. So Zometa is an IV infusion. We give it every 3 months if there's already cancer in the bones. It's about a 20-minute infusion. And what that does, it's what's called a bisphosphonate. So it actually goes into the bone and helps to bring calcium back into the bone to help strengthen the bones. And it's been shown to decrease the risk of broken bones by a pretty significant amount, usually 40 to 50% risk reduction of broken bones in the future. It's also been shown to have some kind of mechanism where it does decrease breast cancer moving into the bones as well. So we do think of it as an active part of the treatment as well. If somebody does not yet have breast cancer in the bones, we often use it in a prophylactic strategy as well, where we give it once every 6 months. And on that schedule, it has been shown to decrease the risk of breast cancer moving into the bones. And we don't quite understand that mechanism yet, but it's been shown from following lots and lots of women that have received Zometa. Okay. So with the CDK4/6 inhibitors, we have 3 different pills: ribociclib, abemaciclib, and palbociclib. And in terms of mechanism, they're very similar. They have not been compared directly to each other. Each of them has been compared to either an aromatase inhibitor by itself or fulvestrant, which is an injection very similar to aromatase inhibitors. So we know from those studies that they all seem to be pretty equally effective. They all prolong life when patients take these medications. And some of these medications now have data about overall survival. So in science and in oncology, we think about how long can you stay on a medication before we see growth of cancer on scans, but also how long can you live overall, taking into account all of the medications that you've received for treatment. So most recently, ribociclib has data that patients who took that one not only had a longer time in between their scans showing growth, but also looked like they were living longer overall. And so a lot of us are now switching to ribociclib as kind of our preferred CDK4/6 inhibitor. There's probably data that's very good with abemaciclib too. We think that there were some issues with the way that that trial was designed. And if somebody's doing really, really well on palbociclib, we wouldn't switch them off of it. We have patients who have been doing really well for years on palbociclib. So I think in general here at Yale, if we're starting somebody on a new medication, we would tend to start with ribociclib, but they also have a little bit of different side effect profiles. And so we take that into consideration regarding which one we choose. So ribociclib has a very rare risk of affecting arrhythmias or causing irregular heartbeats. So we do need to monitor EKGs closely when we first start the medication. So if somebody has a history of arrhythmias or might be on other medications that can increase risk of arrhythmias, we might not choose ribociclib. Abemaciclib is kind of notorious for the diarrhea that it causes, which can be manageable. But if somebody already has GI issues or issues with diarrhea or abdominal issues, that might be a reason not to start somebody on abemaciclib. We talked a lot about how these medications can cause neutropenia, low white blood cell count. So sometimes if they're on one CDK4/6 inhibitor that's causing a lot of issues with blood work, we can switch to one of the other ones and their blood work might actually look better on the other. So that's another option too. Sometimes we switch. Okay, so then often we hope that we can get a long time out of these first treatments, and we call that a first line of treatment. And then eventually the cancer will start to grow on this first treatment. And when that happens, we have a lot of different options depending on what is the resistant mechanism that this cancer has developed. For a very long time, we used to have to go back in and do a biopsy of whatever is growing to try to figure out if there are new mutations that we could potentially target in the cancer. There's now what's called a liquid biopsy. So a lot of these targetable mutations can actually be found through a blood test. And so that's made things easier. And so oftentimes, especially if there's a lot of cancer in the bone can be very difficult to biopsy. It can be painful. It can be just hard to reach that lesion. So we now have the option of doing a blood test to try to find these mutations. So I listed some of the kind of main ones that we look for. So one of the ones that we're looking for is something called ESR1. So is there a mutation in the estrogen receptor that has made it resistant to the estrogen blockers that we've been using? And if ESR1 is present, we now have a treatment option called elacestrant, which is a pill So that's another nice option for patients. And it's been shown to be superior to fulvestrant, which is an injection that's also an estrogen receptor degrader that we had been using for many years before. And so that would be kind of the first line preferred option for somebody with an ESR1 mutation. The other mutation that we're looking for is something called PI3K. And this is kind of another type of mutation that the tumor can sometimes develop a little bit more downstream in the pathway that makes the cancer grow. And if that's present, we have now two different treatment options available: alpelisib, which is a pill that has been around for a long time, and we now have something called capivasertib that's also approved that targets this. Capivasertib also targets PTEN and AKT, so it's added two other targetable mutations that we have a treatment option for in this pathway. It's also important to get what's called genetic testing. So far we've been talking about testing the tumor itself to see what kind of resistance mechanism it's developed. But when we talk about genetic testing, or what we call germline testing, what that's referring to is testing the person's DNA, which can be very different from the tumor DNA, because the tumor is growing out of control and can develop its own kind of mutations. And why is it important to do genetic testing to look at the person's DNA? Because specifically for somebody who might have BRCA, we have a pill form and a treatment option to treat that. So for patients who have what we call a germline BRCA mutation, and probably very soon PALB2, we have a pill called olaparib that actually targets that mutation and can be very effective for treating the breast cancer. And then, of course, we have some older medications. So everolimus is also a pill that has been around for a long time that kind of targets the treatment downstream. So if there are what we call no targetable mutations found on either the blood test or the biopsy, everolimus can be used in any type of hormone-positive breast cancer. And then fulvestrant is an estrogen receptor degrader, and it's an injection. And that can also be used regardless of whether a mutation is present or not. Okay, so I wanted to keep it short, and so this is kind of the brief overview. So the one other thing that I wanted to mention is in HER2. So this is one of the new treatments that's out there that's now targeting what we call the HER2 low type of breast cancer. So sometimes your oncologist might kind of go back because the HER2 low positivity can be on any pathology report. So any previous biopsy that has some HER2 positivity, which we consider +1 or +2, that might make somebody eligible for this new treatment called Enhertu. Are there questions? Yes.
As you said, Zometa prevent the bone cancer. How long does it take?
A great question. So it's not bone cancer per se, right? It's breast cancer that has moved into the bones. When we talk about it as a preventative strategy, so for patients who have risk of breast cancer moving to the bones, but no actual lesions in the bones, we do it for 3 years. So it's an infusion every 6 months for a total of 6 doses. And the reason why we do that is because that's how it was studied. The trial did 6 doses. There is a very rare risk of something called osteonecrosis of the jaw. So it can impair healing of the bone in the jaw. And we think that that tiny risk might increase the more doses that we do. And that's why when we do it as a prophylactic or preventative strategy, we stop after those 6 doses. It's also a very long-acting medication that stays in the bones for a very long time. So it probably continues to keep working. For metastatic breast cancer and for somebody who already has lesions in the bones from the metastatic breast cancer, we would continue giving the Zometa as long as it keeps working, because there is just such a high risk of developing broken bones and more lesions in the bones. Yes. It's called Enhertu, ENHERTU. That's the brand name. Yes. Yeah. Yes, yes, thank you for bringing that up. So hopefully, because Dr. Kahn is talking about the clinical trials, hopefully she'll get into that a little bit more. But yes, you're absolutely right. So there are more of these PI3K inhibitors coming out. And we hope and we think that they might be better than the ones that we currently have. The two biggest issues with the current ones are they can raise blood sugar. So a lot of patients can get what we call hyperglycemia, which seems to be, it can happen more likely if somebody already has slightly high sugar to begin with or has a diagnosis of diabetes. So actually, a lot of the trials for alpelisib and capivasertib actually excluded patients with diabetes, which was unfortunate. So we need a good option for patients who already have some elevation in their glucose or have diabetes. And the reason why it does that is because if the inhibitor is not specifically targeting PI3K in the cancer cells, but is a little bit off pathway, that's an important pathway in glucose and insulin control. And so that's one of the side effects. So we think that these newer inhibitors that are coming out are going to have a lower risk of increasing sugar. The other side effect that we saw with these medications was a really extensive rash that can be really debilitating for patients. It can be really extensive, very itchy, to the point where some patients actually ended up in the hospital from the rash. And so these newer medications seem to have a lower risk of the skin rash as well. And then the other side effect is, of course, diarrhea, which we're still working on. And so that's our hope, that these new inhibitors, by being more targeted, will not only be more effective, but hopefully less toxic. So the Victoria-1 study we have open at Yale. So we do have some patients that are on that medication. And so far we've seemed to have a good experience with that, but we're of course waiting for the final data to come out to see if it's actually more effective and to see if it's actually less toxic. And same thing for the inovolisib. That one, so far, the preliminary data does show that the glucose, the sugar control is much better. So it didn't increase sugar as much as our current treatments did. But we have to see about the diarrhea and the rash and all of the other data, but it seems to be very promising. So yes, in a couple of years, we hope to have even more of those treatments available. Sure.
So if you're looking at
That's a great question. Yes, so sometimes we see more than one mutation. And it's actually currently a debate in the breast expert community of what to do in terms of how to sequence these treatments. So we don't have a clear-cut answer yet in terms of guidelines. And I think, experts vary a little bit. But I would say in general, one of the things that we're starting to look at is how did they do on the first line treatment? So we think that tumors that are very responsive to CDK4/6 inhibitors, and if CDK4/6 inhibitor can control the growth of that tumor for a year or more, we think are more likely going to be responsive to an ESR1 inhibitor. So we tend to, I think, favor elacestrant for patients who had a long period of time on their first line CDK4/6 inhibitor. In general, the PI3K mutations, we think tend to predict maybe a more aggressive tumor type. So if somebody had a shorter amount of time on the CDK4/6 inhibitor, I would favor putting them on a PI3K inhibitor and treating that first, and then saving the ESR1 drug maybe for further down the line. Did that answer your question? Okay. Other questions? Anything that's been confusing that's come up? All right, well, thank you very much. I'm around and I think you get a break and there are refreshments out there. Thank you very much.
Hi. What?
Where, where's the microphone? Where do we see this light?
Oh,
Show you?
oh,
No, but you need to look back like that. Or do they show you?
oh.
Mirror, here, I can put my microphone because I have a template face mask.
Yeah. But are these are not your slides?
Oh, they are.
Yeah.
Just to show little one.
No, I'm sorry.
Okay.
So I was. Maybe he has a portable mic. Let me ask. Alright. All right, we'll start in 2 minutes. All right. Hi, everyone. Hi again. I hope you enjoyed the breakout sessions. The next segment will be an update on our really innovative trials that are part of the phase 1 program here at Yale. This program is led by Dr. Patricia LaRusso, who is really an internationally renowned researcher in this area and the current president of AACR. So she's really amazing, and she's one of the mentors of Dr. Adriana Kahn, who will be speaking, who is one of our breast faculty. And we had, as we kind of envisioned greater collaboration between phase 1 and the breast program, Dr. Kahn was really the ideal candidate to serve as that faculty that lives in those two worlds. So as she sees breast patients, she's very much closely aware of all the important trials that are also available in the phase 1 program. So it's been really the start of a very close collaboration between Yale's phase 1 program and our Yale breast program. And Dr. Kahn is an amazing researcher and clinician who has a role in both programs, and she is involved in a number of investigator-initiated trials, and she very much feels passionately about the clinical trial process, as we all do. I'm going to state the obvious, but it's important to say that every treatment that we have today as standard of care was previously a clinical trial. So I'll hand over the mic to her to talk about our portfolio. Thank you.
Thank you, Mary. Let me make sure I know how to operate this. So nice to meet you, everyone. I'm Adriana Kahn. I'm one of the, not the newest anymore. We have Jing Du over there sitting, who was just started faculty this year, but we are in the newer faculty group. And I trained at Yale, so I was fortunate to be part of the team and be mentored by all of the ones you've heard from today, which is a blessing and an honor. And I've also been given the mission that I much love to treat patients in the breast center and also treat patients in the phase 1 center. So I often see patients that I see myself in breast that I treat in phase 1, and I also get referrals from not only just Yale, but also through the whole state of Connecticut and beyond. We have patients from other states too that come to our phase 1 program just because of the clinical trials we have to offer them. And as you all know, we are always looking for, okay, we have all of these options available, but what if they are not working, or if they're too toxic? What if there's something in my tumor that I don't have any specific therapies for as of the approved list of therapies, but there's this key drug that has been developed and it might be exactly what I need for my cancer therapy, and we have that as a clinical trial. So a lot of patients, after they start doing their own research, and you all probably do some level of like research about your own diseases, they find the trials that they might be needing, and they contact us and we bring them in for a consultation. And we're happy to see patients online, virtually, or in person, but we're happy to educate people on what a clinical trial is and what the options that we have are there. And it's totally, we don't need to do things immediately. We can certainly feed that for the future, and just here's what we have. Whenever you feel like that might be helpful to you, come back. So we like to keep that as an extra tool that patients can use and the doctors can use to treat their patients. So, and I'm very honored to be part of that and to kind of see the future of what's ahead of us in the next 5 to 10 years happening already today, and having the patients that we treat today benefiting from those drugs that are only going to be available much later on. So this is a very pleasant job. I appreciate having it, and I'm very proud and happy to treat our patients. I don't know if this is working, so let me see how to pass. Oh, why did it?
Oh, did it go?
I don't know how it worked. If somebody did it for me, did you do it? Thank you, sir. Thank you, sir. So I'll just drop it. So I just wanted to clarify, what is a clinical trial? So a clinical trial is a study where people participate as patients, or sometimes they're healthy volunteers. So you may have heard people that don't have any diseases necessarily, but just volunteer to participate in a study. They get compensated for it, and then they help move some sort of drug forward. But in our case, most and pretty much 100% of our patients are real patients. And we try to have them having a drug that matches to their disease, so that can not just help that drug move forward, but also help themselves, because that's our biggest goal, is to help the patient that is participating in the study. And you may hear it as clinical studies, clinical trials, research trial, clinical protocols. There's all sorts of names. But the idea is we design something, we create something, and we offer that to patients, and then they participate on it. Every drug comes from an idea. Every drug comes from some sort of scientist who's super nerd, and they're like doing their lives, 30 years of work to find a pathway, something that makes sense to this chain that you may have seen in some of the presentation, all of that cell and all of those things that come one after the other to activate the growth of the cells. So people spend their careers finding pathways, finding drugs that target those pathways to bring that as a medication that can be given either IV or injections or by mouth to patients. And then they initially test that in little petri dish or cancer cells or cell lines. They see that it matches, they see that their concept made sense, they prove their hypothesis, they celebrate it, but that's just the beginning. And then they go and they test that, sometimes in animals, sometimes not. If the animals do not match the human, they need to do some sort of testings around that. But ultimately, whenever they have something that makes biological sense, they were able to create the drug, they've tested in some animals or not, then we need to see that how humans would tolerate it. And then it goes to the clinical trials. Most clinical trials start as give the patients the tiniest little dose possible, because we don't want to hurt anyone. We want to see, how do you handle this tiny little dose? 3 people or so, do they feel well? Yes, okay, bring 3 more, and we go up on the dose a little bit, up on the dose a little bit. And while we do this, what we call dose escalation, we go checking their scans and seeing, are the disease responding to it? Do we need to go higher on the dose, or we got the disease responding and then we can move forward with that dose? How are their blood work? Are we hurting their liver? Are we hurting their kidneys? Are we hurting their bone marrow? So that we know we're not gonna go up on the dose and just hurt a lot of people. So it needs to be a little like an ants work, like making their little home, little by little, to make sure it's safe, to make sure we find efficacy, so that we can expand the trial to hundreds and thousands of patients internationally. So it's a whole process. It starts, and this process takes decades. So a lot of the trials we see available today, they're not just opening from yesterday to today. They've been the work of many people for many decades. So I find that reassuring, because sometimes we feel scared about, like, what is this novel thing coming out of nowhere? We don't know who they are. What is behind it? Know that for most of the trials, they need FDA seeing all of those steps, or European agencies, or whatever they're located, but this is monitored from the get-go, from the beginning. So a lot of these trials had a lot of work behind and approvals behind to make sure it's done as it should properly be done. So we have phases, and you may hear this phase 1, phase 2, phase 3, and it can get confusing. So the clinical trials, they started as I was mentioning, little by little. We're making sure this is safe. We're making sure that we find the right dose before we can expand the dose and look for more patients. Phase 1 clinical trials are the initial ones. So we have a small amount of patients. Normally it's 100 to less than 100 to a little more than 100 patients through a whole many places, not just in one site, in most of these studies. And we go escalating the dose until we find a dose that is safe, and then we can expand it. So phase 1 has a dose escalation and a little bit of a dose expansion. Then once we get the dose, we are comfortable with it, it goes to phase 2. And then we put more patients at that recommended dose. We say, okay, we got the dose, let's put more patients on that dose. Then that's phase 2. We say, okay, is it working for their cancer now? I got the best dose I could, it's safe, is it working for their cancer? So we're looking for efficacy. Then if we say, yes, it was efficacious, I'm seeing cancers coming down, I'm seeing patients responding, then we do a phase 3 study, which most of those studies are, okay, you got your drug, it's safe, it's efficacious. Now I want to know, are you better than what I already have? Is it worth putting that through the market if it's the same as what we already have? So phase 3 is in general when they go head to head with what's already available, what we call standard of care. And then we do a larger study as a standard of care. And then we say, yes, this is good, it's efficacious, it's safe, and it's a little bit better, or a lot better than the standard of care. Or even if it's not that much better in terms of efficacy, but if you show that it's much less toxic than what we have, great job. So the FDA's job is to judge, is this worth approving because it was either better or better and less toxic to the patient? So then that's when a phase 3 study gets approved, and then it goes to the community. And then rarely more so than the others, we have phase 4 clinical studies. So now we have a drug that it's already out there, and HER2, Trodelvy, all these names you hear. Then they can do studies in populations that were not necessarily included in that initial study. For example, we can do a phase 4 study for the African-American population, for the Hispanic population, for the Asian population, for older patients, for younger patients, for patients with kidney functions that are not as sharp as the initial trials included. So you're looking for the after marketing. The drug is already approved, but that doesn't necessarily reflect everybody that we treat the patients with. So that would be a phase 4 study. So at Yale, we have all of them. And that's what Mariya was saying. I'm part of the phase 1 program. And then we have as all of our breast oncologists are part of the phase 2, phase 3, phase 4 studies. And we have other doctors in the phase 1 program as well. Just showing the percentage of drugs that start. By the time that they go through the filters of FDA approval, just about 30% of those drugs get ultimately approved by the FDA. But a lot of them stop before they can go forward because of either lack of efficacy or lack of safety. And who should enroll? Like who do we think should enroll? The main answer to that is everyone and all of us. We try our best to make the inclusion criteria of the trials. They were historically very exclusive. They were like, oh, I just want this patient, that patient. We're trying our best to make things more realistic, because what's the purpose of trying this drug in an Olympic champion and then we'll go to the normal patients and say that doesn't really help. So we're trying our best to expand, and that's a mission of national, international clinical trials currently. And we have committees, and we have diversity committees, and we have all sorts of efforts to improve and expand inclusion and eliminate some exclusion criteria of the trials that would say people, you're not eligible to this study. But the idea is for patients who their standard therapies either are not working or the drugs are maybe too toxic and they just can't take more of those drugs and they need something that might be newer. And that might be something smartly targeted to their cancer. And that normally helps advancing science, because if it can develop this drug, then if it gets approved, it will benefit thousands and millions of patients throughout the whole world. And potentially that would benefit their own patient. Oh, try clicker now. Thank you. We have a paper that is very historically famous between the oncology people, which is the hallmarks of cancer. That just shows us why are cancer cells so stubbornly smart? Why can they just keep growing despite all of the things we do to treat them? And then we have a ton of pathways that we realize that cancer cells use to survive. They can resist being killed by the immune system. They can create vessels that feed them more than they should be fed. They can activate pathways that help them infiltrate tissues that they shouldn't be infiltrating before. So there's a lot, and then genes and mutations that make them spread and grow faster than they should. So cancer cells are survivors, they're fighters. They're trying like, okay, you're trying to kill me, then I'm gonna be killed and find some strength and grow stronger and try to go back and forth. So it's a battle between us and the cancer cells trying to find therapies that work, but we use the ideas that we've discovered as strategies that the cancers use to survive as potential targets to treat them. So a lot of the studies that you've heard of and drugs you've received and the studies that I'm gonna mention, they use some or combination of all these mechanisms of survival from the cancer cells. I have an example of a patient. I'll try to be fast just for a matter of time, but she's a female patient who's African-American, and I treat her in phase 1. She was diagnosed initially with early stage triple-negative breast cancer in 2017. She was treated with an initial clinical trial that combined immunotherapy with chemotherapy, which at that time was not yet available as a standard of care. So she got that much earlier than as it is standard of care today. She had her surgery, radiation, and chemotherapy after surgery, but then her cancer came back in 2020. Between 2020 and 2021, she received a few chemotherapies and antibody drug conjugates. Sacituzumab govitecan was the one she received. And that took about a year and a half or so, but then the cancer was able to learn how to get out of there. And then since 2022, she started work with us in the phase 1. We were offering clinical trials. And she participated in 3 back-to-back studies so far, but none of them are chemotherapy. They're all pills. She tolerated them just fine. Some of them lasted a whole year and a half, and then the other ones were a little shorter lived. But if she didn't have, since 2022, metas or participated in clinical studies or being offered to participate in clinical studies, she would have gone from 2021 to chemo and chemo and chemo. And although some of these chemotherapies could work for her and could still give her a response, they sometimes bring more toxicities than some of the novel targeted therapies. So I just wanted to bring out there that if we don't offer, patients might not benefit. Not everybody benefits. All of these drugs we're trying, like we're hoping that they would help them, but that doesn't necessarily help everyone and everyone all the time. But for some patients, if it does, if there's one drug or one trial that lasts a while longer, we can postpone the need for regular chemotherapy. So I just wanted to bring that up, that there is a lot of myths around clinical trials, but once and this patient, for example, in the beginning, she was like, I'm not too sure about it and I don't know about it. And there's a lot of myths and a lot of community experiences from the past that is genuinely worrisome, and they have the rights to question. But once we speak and we chat and we show what the trial is all about, and then they participated, they start to see, yeah, there might be more to the story. Maybe what happened in the past is not what's happening today. The people that are treating me today are not the people who did things in the past that were of question of ethics, of behavior, ethical behavior. So we're hoping to change that and to offer patients therapies that they would never be able to have otherwise, and postpone their lives with quality, which is what matters the most, is with quality. So I brought not just the Yale trials, but not just the phase 1 trials, but I'm mentioning also some of our regular breast cancer clinical trials that include patients with metastatic breast cancer. Hi. Oh. So I wanted to show a little bit about the antibody drug conjugates. These, if you look at that, it's a little confusing, and we try to explain as this antibody trying to target some sort of cell and bringing with it some sort of chemotherapy. I like to use metaphors. So it's almost like a Trojan horse. So you have this drug that comes, knocks on the cancer cell door and say, hi, nice to meet you. It seems fine in the beginning, but then when you invite it in, it brings this big chemotherapy bomb, and it just bombs the whole cell on the inside. So that's what antibody drug conjugate does. It meets the cancer cell, it gets inside of it, and then it releases the chemotherapy bombs. And then it's shown in clinical studies to be more effective than regular chemotherapies. For many of these antibody drug conjugates, we have Enhertu, Trodelvy, they all did better than regular chemotherapies. And we have many newer ones, hundreds of them, that now all the companies through the globe are producing and trying to bring into a clinic. One of them is datopotamab deruxtecan, and we have a few clinical trials with this drug here at Yale. Their names are super long and confusing. Datopotato is how the surgeons call this drug. So it's an antibody drug conjugate, one of those Trojan horses, and we are using them for patients with triple-negative breast cancer in a few settings. As soon as they get diagnosed with early stage disease, or if they do get their initial therapies and then they get surgery, but there's residual disease, we try to use this drug as well as to try to, like, okay, whatever chemotherapy didn't do, let's try to do better with this drug. And also in the metastatic setting. So we have a currently open trial in the first line. As soon as they get diagnosed with metastatic triple negative, they can get this drug available. So we're trying to see, can we do better than the drugs we already have in the same family? Are for some reason, the novel drugs or different versions of these drugs, are they less toxic? Are they better tolerated? So we are offering this drug to lots of our patients. We have another one that is novel, that is a HER2 eribulin. most of the ADCs or these antibody drug conjugates we have, they have the same type of bomb. So the bombs that they throw inside the cells are kind of like the same family, and the tumors sometimes can say, I've seen that one before, you're not gonna scare me anymore. And then now the companies are creating Trojan horses that bring different family of bombs. So like, oh, I wasn't expecting that one. So this one is a Rebellion, which is a different class than Trodelvy and HER2. And they have seen efficacy in patients post in HER2. So there we have this trial open at Yale to treat patients with metastatic disease after in HER2. We also have novel endocrine therapies. You probably heard a lot from Dr. Rozenblit on the estrogen and endocrine mechanisms of actions. And we have tamoxifen, aromatase inhibitors, and fulvestrant as classic drugs we use. We have novel ways to destroy the receptors of estrogen. So one of them is called a PROTAC, which is putting a wanted sign in the face of the bad guy. So they come in the estrogen receptor, put a little flag and say, here, this is the one you should kill. And then the body comes and destroys that. That's a technique that was developed earlier at Yale, and now it became a medication, and now the medication is being studied by Pfizer. And we have this drug, we have a few of them at Yale, with the drug called vepdegestrant. Again, names are super hard to pronounce. Plus novel CDK inhibitors. We have CDK4, CDK7, and we are treating patients with hormone-positive metastatic breast cancer with these novel drugs. And we are not only using this new destroyer of the estrogen receptor or vepdegestrant, PROTAC, but we are also using novel CDK drugs. So we have, and you may have heard of Kisqali, ribociclib, Verzenio, abemaciclib, Ibrance, palbociclib. We now, Pfizer and other companies are creating novel versions of that. We know some of these drugs can cause low blood counts. We know they can cause diarrhea, they can cause fatigue. So what if novel targets of that same family can do the same good job, but with less toxicity? That's their hope. And we are offering that to our patients. We also have drugs targeting the androgen receptor. So this is an old friend of our oncology life, and we tried to target that before, and it wasn't really effective. But some patients, when their estrogen pathway gets treated, the tumors use the androgen pathway as like, okay, you are trying to eliminate the female hormones, let me use the male hormones that I have to see if I can survive. So now a company created a novel way to treat that pathway. So we're seeing if that is gonna help patients, and that's one of the androgen receptor studies that we have. And we have elacestrant, which is a destroyer of the estrogen receptor. We have the corresponding drug of elacestrant is fulvestrant, which is given as a shot in the muscle. The company created elacestrant, which is the oral version of that. Instead of a shot, you can take it by mouth. And we normally give that to patients as a single agent drug, but we know fulvestrant is often combined with something. So now we have a trial that is combining elacestrant with all of the other target drugs that we already use in clinical practice to combine that drug with, fulvestrant with, but now with the oral version of it. So we can spare patients from the shot in the muscle, and it's also shown to have a higher efficacy than fulvestrant. So we're hopeful that this would be soon approved by the FDA so it can become option to patients. And we have all of these cell signals and all of these pathways that can be super complex, and they are. We don't even know all of them. We're still developing knowledge about how things work, but one of the big pathways is called PI3 kinase pathway. And a lot of you may have heard of it or may have tumors with these mutations yourselves. It's a pathway that helps cancer cells escape the treatments that we do, and it helps them grow. Some side effects of the drugs we have for this pathway today, they can cause some side effects that are not desirable. So they can cause rash, diarrhea, and most bothersome is high sugar. Some people need insulin. They struggle a lot with that. We can of course, monitor for that and treat patients with medicines for sugars, but it can be a bit of a process. So novel drugs are coming to see if they can do the same job without bothering the blood sugars or the rash, diarrhea as much, if they can make better versions of these drugs to make them more efficacious. One of them is gedatolisib, which is a trial that we have currently open at Yale, and it's combining that drug with palbociclib and fulvestrant, including patients with hormone-positive disease. And then on phase 1, we have, I'll pass a few more. We have a trial with a newer PI3 kinase inhibitor from this company called Scorpion, that it's more selective to the PI3 kinase of the cancer cell and trying to spare the regular body's PI3 kinase, which is how it causes all these extra symptoms with sugar, diarrhea, rash. So this drug is also available by itself in combination with fulvestrant and with the CDK4/6 inhibitors. And another version of it is a company called Totos Therapeutics. It's also bringing a novel PI3 kinase medication, hopefully to help a lot of our patients with less toxicity. Then we have another pathway, which is the DNA damage repair. So cancer cells, they have all these mutations and they often die because those mutations make their cells not very effective, but they create pathways to survive, to recover themselves from all these mutations that they have. And that's what we call DNA damage repair. Most of the patients that benefit from these types of drugs are the ones with those mutations that you may have heard of as BRCA or BRCA mutations. We have a medication called olaparib and another one called talazoparib that are approved, but they are not including all of the mutations in the family of these types of mutations. So we have patients with PALB2, CHEK2, CHEK1, patients with RAD51 mutations, patients with other mutations in the family, and we don't know if other drugs can help all of these other patients and families of mutations. So newer drugs are coming, one from Roche with the USP1 inhibitor. So all of these names, and for sure, ask me more about it later because it might take a while to explain all of them. But pretty much we have novel ways to use drugs that work kind of like olaparib, but in different views, like hurting the cancer in different phases, to see if we can achieve benefit. And that most of these trials include patients that had olaparib before, and then they can get onto these drugs one after the other. And that's the case of that patient that I presented. She's been on 3 of these studies, and one was super long lasting, the other ones lasted a little shorter, but they were all oral and she tolerated them just fine. So we are hoping to keep going and having her treating with those drugs for a while longer. These are more options. We have drugs that are trying to be less toxic than olaparib because they sometimes can cause low blood counts. So these novel drugs and versions of it are trying to be less bothersome to the body. And then we have immunotherapy drugs. So this is a picture showing the T cell is our little soldier and the big green one is the cancer cell. And then when they finally meet, the blue cell, which is the body cells, can destroy and explode the whole cancer cell. Sometimes the cancer cell, though, creates a little mask that says, no, not here. And then that blue cell can never reach it. But we know that if it does reach our immune system is super smart. And we know it can kill the cancer cells. We just need to help it do it because the cancer cells are trying their best to mask themselves from it. So we have a number of drugs in this pathway of the immunotherapies with novel targets in the immunotherapy cells. And I listed them here. We have bispecific antibodies. We have other immune checkpoint inhibitors. Drugs that help the immune cells infiltrate through the tumor better. BioNTech, which is the company of the mRNA vaccine, also has cancer cell drugs trying to create mRNA that reads in the body soldiers to go and kill cancer cells. And we have, just wanted to bring to our attention, we have a CAR T cell. Some of you may have heard of CAR T as a therapy that is used in blood cancers, and it's super effective. And now we have this study open at Yale that uses this type of therapy in triple-negative breast cancer, which is you draw the patient's blood, take that blood to a lab, make that white blood cells expert soldiers and bring them back and infuse them back in the patient. So you create a little army and say, go back and fight. That's what CAR T is in a little summary. And then we have that now open at Yale to help our patients with triple-negative breast cancer. And I listed many other trials we have. There were so many, and I'm glad to say that there's a lot of them because you can have access to slides and all that afterwards and just see what we have currently. And this is very dynamic. We are opening trials constantly. So we're happy to offer many options to all of our patients and targeted therapies too. So I heard Dr. Schellhorn's presentation saying sometimes we sequence the patients to look for mutations and we say there's nothing targetable, nothing standard of care. In phase 1, we are looking for all sorts of targets that we don't even hear of in the standard of care life. So know that there's more options depending on what your tumor might have. And as a just closing comment, I wanted to make sure we're trying our best to take trials to patients and we're trying to be inclusive and include diversity in our clinical studies. And I wanted to thank you all. Thank you, your families. Thank you, patients. Thank you, the teams that help coordinate all of this. Is a huge effort that we do as a whole community to try to bring trials to patients because ultimately I see all of that as hope. And I think we can never lose it. We needed to move forward and patients needed to move forward. So we're happy to offer that to our patients. Thank you so much.
Thank you. Thank you, Dr. Kahn. She'll be around for a little bit if you have questions, but to keep on track and make sure that you have your full time for our excellent breakout sessions. We will not open it up for questions at this time. So we're going to separate again. We have two wonderful breakout sessions planned for you. And it's hard to pick between the two, but just listen to your heart in terms of which you want to focus on today. If you want to learn more about exercise, diet, and nutrition, we have two amazing experts for you who will be downstairs. Melinda Irwin and Mara Harrigan can meet you downstairs for that breakout session. And then depending on your needs, if you want to talk more in an intimate setting about communication and conversations with family and children around the topic of cancer diagnosis and any other challenging discussions that you may be facing, we have an amazing expert, Dr. Nancy Borselman, who will be leading that breakout here in this area. So if you can kind of decide, oh, everybody does both. Thank you. Then you'll flip. Then you don't have to choose. Thank you, Sandy. So, so that's great. So then the choice, there's no choice. You get to benefit from both. So how do they decide which one? Okay. Okay. So the back area, go downstairs for the nutrition, and then we'll flip you over. Sorry, Sandy. Keeping me straight.
Give me a brief tutorial. Do I? Okay, so
Yep.
And then do I need to use the microphone?
Nope, she wanted to because she didn't want to stand. So this
Oh.
one stays, or you could use that one.
Okay. I'm just trying to think. That's so big. Does it? It's not showing here though. I'm sorry. I'm just trying to figure out how to.
She can use that one or stay.
Oh, good morning, everyone. I think we want to get started. I know we have only a half an hour, and I think I could talk for several hours. So we want to get started. I've just introduced myself. I'm Nancy Borselman, and I'm on faculty at the Yale Child Studies Center, and also co-director of our early onset cancer program. And what we're talking about this morning is something I think very critical and very that I feel very passionate about, is how we talk with our family members when there's cancer in the family, and also how we talk with children. So, and just to, by way of sharing some of my sort of goals for right now, and also philosophy. And what that really is how to share information, guidance, and research with you in a way that makes sense and is useful. And to know that what I'm sharing here today is probably many, many years of my own experience with working with families with cancer, but also that has been guided by best practice over what we have learned has been helpful for families. And I do have to credit the many, many families, cancer patients that I have worked with, and some of their children and teenagers and young adults who have helped me understand what's more helpful to them. So, and another point about this is the true value of open communication, and that while I'm sharing these, insights or guidance or suggestions, you all are really the experts on your own life, but on your own family and on your children. So dealing with how we talk with others is really critical and sort of sets the stage for how you have to cope with many things that come up over the course of your cancer care. And it's necessary and challenging, and it's not just one conversation, it's many over the course of time, and it never follows a straight line. So how do we think about this? So a sort of established process that I think maybe you all know and probably have experienced this, is that it starts with where you are. So how do we check in with ourselves and really reflect on our own thoughts and feelings? Because talking with others is not just about where you are, it's also where they are and about the relationship that you may have. And it's a very valuable step. So although we're all adults, and thinking about our own thoughts is something that you do without necessarily being aware of it. But in proceeding or going forward with a complicated conversation, or even just telling some news, is just knowing where am I today? And processing that can really help you feel more prepared. Because as you think through your own kind of where am I today, it allows you to be more in charge of your own emotions that can necessarily, and of course understandably, arise in any conversation. Some patients I know have spent time talking with either friends, family, therapists, counselors, spiritual leaders, others, in preparation for certain conversations, or sometimes sitting with your own thoughts in a journal, and just really taking some time to think about where am I? How am I feeling? So one very common referral that has come to me over the many years of my practice has been about, how do I talk with children? How do I tell my kids? When do I tell my kids? How much do I tell my kids? Kids of different ages. And I think many, many parents, and I understand, I have 3 kids myself, when tough things come up in your life, it's natural to want to protect, because that's what parents do. That is a big job for us. And yet when you have children and you have cancer in the family, one of the sort of key principles, I think, to guide how you proceed and how you think about things is how to be open. And that children and families do best, and we know this from our own practice, but also from a lot of research that's been done in this area, that it's kind of an error of kindness. In other words, it comes from the best place possible. But yet, the way to really help your kids is to share with them. And kids really want to know. And if they don't, hear directly from you. They may hear it from someone else. They may overhear it. And that is a really tough way to get information. Another important point is that when you have open communication, is you open up space to ask for kids, others to ask questions or to share their worries or their concerns. And that it's a really important thing around feeling alone and isolated. Cancer can be a very isolating experience, and not only for the person with cancer, and I maybe in this audience today, we have some of you who are being treated for cancer and others who are family members, but just no matter who you are, cancer has affected your family and it's rippling through, and everyone can feel it in different ways. Silence is also something that can lead to misunderstanding and mistrust or distress. So really valuable to be open and honest. So just a few points on navigating. So honesty is one of the principles that we're talking about. And also not necessarily every detail about everything, but what do we need to know now? What's going to be noticed, or what's going to really be a concrete change in someone's day or routine? Trying to keep things normal, which I know could be a tall order when there's so much going on, but routine, predictability, as much as you can do, knowing that cancer care is a very dynamic thing and can be very disruptive. So just planning and thinking about, okay, where can I keep things like they usually are? Acknowledging uncertainty. There's not everything is known or clear. And sometimes it's helpful to just say that, you know, I don't know the answer to that. I'm not sure exactly what that's going to be like, but I'll let you know. Expressing feelings is healthy and helpful. It really helps in the space of sharing information. And it's interesting how children, when they're asked about this, they say, well, I told my mom about my after school sports. I told her about this. She hadn't thought about that. So then we figured out, how am I going to get picked up on those days that she has to go into the clinic? So sometimes kids really feel a part of something in a very helpful way. And they can help you because they tell you things. Okay. So just, I'm going to go through some slides around different age groups of children, and we'll have to go through rather quickly, but I'm happy to answer any questions during the lunch and whenever. So just what is developmental understanding? It's really what's appropriate for kids of different ages. It's the way that children understand the world around them, the lens through which they see the world. And thinking about conversations in general is not just a conversation writ large, but it's really a lot of small conversations along the way. So, and when you are in cancer care and you know you're going to be in cancer care for a long time, it's really helpful to set this foundation, particularly when there are times when you need to have a pivot conversation. What I mean by that is something's changed. There's a shift in treatment. I have to go in more often. There may be a surgery or a hospitalization or a change in caregiver or some routine. So when you've been already discussing this and talking about this, it's helpful because it doesn't come up as a surprise. So again, creating this space so that children have permission, quote unquote, permission, meaning it's okay to ask questions. Sometimes kids hold back because they aren't sure if it's okay to have that thought or have that question or feel that way. So the more you have an open space, the better it is for them. They may or may not tell you, but at least they know. They know. Even kids who are quiet and don't ask questions, they're thinking, but then they know if they did, they could come and talk about it. news bulletins. So what I mean by that, I'll go to the next slide, is just updates. Sometimes it's just a way of thinking about, oh, we're going to have a news bulletin tonight, or we're going to have and kids will smile about that. And it can be 2 minutes. It can turn into a long conversation. But it's really just, I have some news to tell you. I have something I want to share with you all. And then you can just say it, whatever it is. And then this is the time to pause and let them take it in. Sometimes less is more. When we get anxious as humans, we can sometimes talk a lot, and a lot keeps coming out. And so in that case, just try to take a deep breath and give yourself a moment. And there may be questions, there may not be any questions, but it's a space to just share about what's going on. So across all ages of children, I wanted to just say these 3 things, that even older children, surprisingly, can think that they may have done something to cause cancer, or to make your illness worse in some way. And it's not logical, but it can be something that they're struggling with. And so just literally saying, I want you to know that nothing you said or did caused my cancer. Cancer is not an illness you can catch. Again, even older children can sometimes get confused by this. And again, it's more like a broken leg. I found that to be a helpful way of thinking about it, and not like a cold. All kids need a sense of comfort, of security, and about what's going on and who's going to take care of me, no matter how old they are. They may need it in different ways, but they may not show it, but they still need it. So I'm going to go through these slides on some of the different developmental stages. So infants and toddlers. So a baby or a little one and 2 and under, they're not going to understand. However, what they do notice is the change in their routines and the feelings around them, because babies and little ones, they are wired to be very sensitive, and so they feel it. So they can get a little upset or not sleep as well, or it might disrupt their eating. But essentially, the more consistent that you can be, and with caregivers or routines, the better. And just a lot of contact, hugging, holding, soothing. Younger age kids, 3 to 5, again, very basic, and a reminder that you can't catch cancer, but they also have something called magical thinking. So it might be, I did something like, I couldn't sleep, and I was crying and fussing, and I kept mommy awake, and then mommy was so tired, and I think I made her sick. And so again, being able to talk with kids and reassure them that nothing they did. And then they usually go on about their play. Kids of this age are very self-centered. That's how they just are put together. That's how they think about things. So they can often come back with the same question over and over again that you just answered 2 minutes ago. And you said, I'm really tired. I need to rest right now. Can you play with me? And so sometimes just a distraction of, I wish I could play. Sometimes a wish statement is helpful for kids. I wish I could play, but I really need to rest. Could we sit together on the couch and draw some pictures? Sometimes kids this age also do a lot of play through about how they're dealing and feeling about things. So it might be with their dolls or with their stuffed bear. And you see them taking care of the bear, or putting the doll in a car and zooming around on their way to the hospital. And it's a time when you can just say, tell me what's happening to your bear. And then honestly, most kids just go on about their play, but it's just recognizing that this is just how they do, and not to be alarmed about it. It's their way of making sense of their world. For kids in the 6 to 12, sort of this, and these are very broad because there can be a lot of difference between a 6-year-old and a 12-year-old, but in general, they sometimes when stressed will act younger. than they typically would, sometimes even surprisingly baby talk. But it's a way in which they're expressing their feelings, but also a way of getting attention in some ways, like I might need something from you. They can ask a lot of questions. Kids at this age are just sponges for information. So they may ask about everything, about hair loss. Why do you have those bandages? What's that thing over there? And simple explanations. And sometimes a sentence or two is plenty. You don't need a lot of detail. They can sometimes get angry because I can't do what I want to do. And that is also sometimes a response to being sad about it or not understanding. So it just gets expressed as being angry. So simple, brief explanations, reassuring them that quote unquote stressing you out with their less than perfect behavior, as many kids have, or things going on at school didn't cause or make you sick or make your cancer worse. Thinking about school, this could be we could talk a lot about school, but because kids spend so much of their time at school, and it can be an island of normality is the way I think about it. And one aspect about school is to encourage kids to bring their questions or concerns that might come up at school to you, because sometimes other kids say things that are confusing or upsetting. Sometimes teachers ask questions, so it gives you a little bit of a heads up. Sometimes complaining about stomach aches, headaches. And usually when that happens, you might get a call from the school nurse, but you can always check in with the school. It's hard to protect especially teens and young adults from the internet and social media. I mean, it's everywhere, and that's probably where they live more and more all the time. And I think what you can say is there is a lot out there that is not accurate, that can be scary, confusing. Is there anything worrying you? Is there anything that you heard that would be good for me to know about and we could talk about? And you can answer the question the best you can, or bring it to your team and get answers, or try to redirect them to reliable resources that are where you know the information is helpful, as opposed to frightening, scaring, or just strange. Teenagers and young adults, and sometimes younger kids too, can be sensitive to how they feel different. So that's a place, again, for talking with them. And again, sometimes there's not much you can do about that because this is the situation, but I think just the fact that they could share it with you, or that they're talking with friends or others. Sometimes strong feelings, teenagers. And if you think about this fight, flight, freeze, you may have heard about this in other contexts, but what that can mean is acting, and this could be family members too, acting with frustration or anger, just withdrawing and not being available, or just not saying much. And that's sometimes because they are trying to figure out how they feel about something, what they're thinking. Teenagers can also be, because they are developing their own identity, very self-focused. And I think a lot of parents can get frustrated about this. They just don't think about how to be helpful. So a response to that is to be as clear as you can be. And it may be reminders or things posted, but about expectations, responsibilities, and limits. It can be hard sometimes to stick with the expectations and the limits when you've got a lot going on, but a few reminders, please make sure you're home by 6 p.m. I need help with dinner and your siblings, or I need a check-in call or a text when you leave school. So just clear, simple, and just repeating it. teenagers are also trying to figure out how to do their own thing. Independence is primary, and privacy. So it's important to respect it, but to also know sometimes they still need and want closeness and comfort. You know, they may not want to say it, but they want to know you're there for them. So, and it can come up in, you know, the talking side by side in the car, so I don't have to look at you directly. That can be a place to just do a check-in, or finding a way to share something fun together. So living with cancer as a family, so just a few sort of wrap up points. Support over solutions. So it can be really hard not to be able to control what is happening or not to be able to make it better. What's been on your mind? Can we talk about that? So there's not always an answer for everything or a way to just fix it and take it away. Listen, worry to the worries, to the needs, the feelings, validate. So that means just helping the child, your young adult, the family member feel seen and heard. And the validation is something like, it's natural to be upset. I'm sometimes sad and frustrated too. And it can be hard to talk about this. And I'm here when you want to, because sometimes not everybody wants to talk at the moment that maybe you would like to, but just to know I'm here if you want to. Can we make a plan to talk another time tomorrow, you know, later when we are sitting down before dinner? Reassure. I wish it were different, and what can we do to make things better? So this is a strategy called both and. So you say, I wish it could be different, and not but, and here's some ideas I have about what we could do to make this better, or this is a lot to take in, and here's some ideas I have. What ideas do you have? So there's something about hearing that in that way that helps open up the space for conversation. I'm going to go over a few points that relate to general communication. When you're talking with caregivers or others in your family, I did a lot of research work on cancer caregivers, meaning family members or others who are supporting cancer patients. And I think one of the key things that I have taken away is really helping to figure out what are the ways to support each other. In other words, emotional support. Is it more practical support, logistical things that need to be taken care of? Is it information? It's just too much for me to take in. Can you help find out more about what your child needs for school, or how to figure out another childcare or situation? So it's those three categories: information, the emotional feeling support, or logistical practical support, and sort of helping to figure out who's going to do what, and are we on the same page? So what about talking with children, or sharing information with friends, asking and receiving help? These are, I think, really critical topics that sometimes it's good to just put out there. You know, are we really on the same page? And how are we going to figure out what to do about our different ideas? What about talking with work or school? A few points about honesty. It can be very challenging to say what you want to say, whether it's about the current situation that you're in right now, a change in your treatment, about how you're feeling, about your frustrations, about the future. And sometimes there are questions that come up. And is it something that you can do together with your family member, or with your spouse or partner? Do we need to put a list together to ask the team? And again, it's just a way of sharing this, because there's often a lot of questions. And caregivers, family members can feel isolated and kind of sitting with their own thoughts and worries and not really sure, is it okay to ask that question? Being patient and listening and asking questions. Somehow we are, I think, again, as humans, often want to take care of things and fix them in the moment, but we can't always fix things. So it's more about, are we in it together and can we figure this out together? Empathy. So empathy is, I can try to put myself in your place, not what I think of it, but how I think you may be thinking about it. So that is really a key element of mutual support and opening up conversations. What's happening right now in the current situation, and what are things that we might have to plan for? Changing roles and responsibilities. Just really naming that, like, I used to always do this particular thing. I used to always take the kids to school. I used to always cook dinner. Now my spouse has to do more of that, or my 18-year-old is going to help with pickup. And it's all good that everybody's working together, but it's acknowledging that that is different. That is different. And as humans, we're also quite adaptable, but it doesn't happen as easily if we're not talking about it. Focusing on what's important. It's really, it's hard to change what you do sometimes because that feels like being normal. But sometimes you have to step back and say, can we just settle for good enough? I'd like to make the perfect something or have this family member over and do dinner, but I have to cut back. I'm just going to have to settle for good enough when it comes to certain things. And lastly, just getting organized. Something that is important to do together with family, or get the kids involved where they can be involved. Talking through appointments, planning, figuring out calendars, making sure you've got important documents and information where you can find it. Sometimes the scramble is hard. Everybody finds a different method, whether it's calendars or color coding or things on the fridge, but finding a way that works for you. Discussing legal and financial issues early on. Most people, regardless of having cancer or not, do not ever want to talk about these things because that's human nature. Talking about legal issues, money issues, sensitive issues are often avoided. That's just how we are as people. But really taking time to sit down and think, are there areas like my healthcare proxy or my will or advanced directives? How we talked about any of this? Have I thought about any of this? And it doesn't mean you have to dive in, but it's a start. And you want to do those things when they're not urgent and in a crisis. And for family members, caregivers, and others, helping to encourage them to educate themselves, inform themselves, and find support, because everybody needs support. I just wanted to mention that at Yale, I'm co-directing the development of this early onset cancer program. And this is for patients, all cancers, diagnosed between the ages of 18 and 50. And our goal is to really put together research, psychosocial care, look at our clinical care for individuals of these ages, and also to focus on the community and outreach and how we can better help our community understand what we have to offer and how they can also help themselves in early detection, but also screening. And I think I'm at time. So, but I don't think we'll have time to do this breathing exercise, but I did want to mention that one thing we have with us, no matter where we go, no matter whatever we're facing, is our breath. And that doing some very simple, gentle breathing exercises, and I'm happy to send those out with some other resources can really help just ground you and make even the next tough thing just a little bit easier. And just really appreciate the challenges that all of you are facing. Cancer really is serious business, but it's a lot, there's a lot of ways to do it. And I hope I have offered a few ideas or suggestions in this regard. And I just want to end with that life is not only cancer, even though it feels like it's overwhelming and taking up 99% of your time. But think about what relaxes you, what makes you laugh, and what brings you peace. So thank you all so much. I don't know if we have time for questions, but I'm going to be around at lunchtime. So if I could answer any questions, I'd be more than happy to.
So now we're gonna go downstairs and come back.
Hi, everyone. I think we should probably get going because I know between you and lunch. Um, so I'm Nancy Borselman, and we're here to talk about conversations and communication with family and with children. I'm a faculty member at the Yale Child Study Center, and I'm also co-director for our early onset cancer program, which I'll touch on a little bit later. And my background is social work, clinical social work. I got my MSW and then I got my PhD in social work, and also have a master's in public health from here at Yale. So let's dive in. So one. Oh, there we go. Okay. So I just thought I'd touch briefly on some of the goals, what I hope to accomplish today, and also some philosophy related to conversations and communication. This is I hope will be helpful around providing some guidance, some suggestions, some ideas about talking with family, partners, children of different ages. And sharing this information is really guided by research, by also clinical practice, and also from working with many cancer patients and their families over years who have taught me a lot about what's helpful. And I have really appreciated that and have incorporated it into how I think about and help take care of those who are living with cancer. Addressing some common concerns and questions that can come up, and all while recognizing that you all are the experts on your own lives, on your own families, and also if you're parenting or grandparenting, you are the expert on your children or your grandchildren. So dealing with how to talk about cancer and how it's having impact on you and on your whole family really does ripple out to everyone who you know, especially those who are closest to you. And it's really a very common question that comes up from patients or from their family members is, how do I talk with my children? What should I say? When should I talk about this? How do I talk about it? Or should I talk about it? And these can be some of the most challenging situations that a patient can confront. And it's not just one conversation, it can be many over time. I also want to just note that these are, general points of guidance, and that there are a lot of unique situations. In other words, some children have very particular needs. Some family members might be more complicated than others, but in general, I think some of this guidance I hope will be helpful. So how do we think about this? I think one of the most important points of guidance I can offer today in some ways is knowing how you are. So before you go into any conversation or communication with children, others in your family, is to really check in with yourself. How am I? Knowing your own thoughts, knowing your own feelings, taking a moment to reflect on that. And one of the key principles behind this is when you are trying to manage your own, my head is rattling around with lots of thoughts, or you're trying to manage your own feelings, it takes away from how you're going to be able to be there in the relationship that you're in and talk through together. It helps reduce stress. So what you can do to process some of that before you have a conversation, whether it's just taking a few deep breaths or thinking out, what do I really want to say? What's my goal? What am I hoping to talk to my family member or child about? And whether you process that yourself or with a friend, or some people like to write in a journal, or just even make a few notes, just so that you feel like I'm a little more ready for this. So I'm going to spend some time talking about sharing news with children. And one of the principles or philosophies that we have in our work, but also I think in general and through the Child Study Center, is how do we support open communication? And what that means is really how do we create space so that we can talk about things that are not always easy to talk about, but when you talk about things, they become more manageable. It doesn't mean that they're easy, but they can become more manageable. And it's natural as parents or grandparents or family members to want to protect. I have 3 children myself, and I completely understand this. And it's what one of my colleagues has called an error of kindness. In other words, your best intention is to want to do what parents do, which is care for and protect your children from hard things or from things that might upset them. But in essence, children do better when they are engaged in open discussion, when they are included. And one thing that we know, and I can imagine that many of you here may have experienced this, is a sense of being alone or isolated. And one of the things that you can do by opening up space for conversation is that people, children, others feel included. They may not always want to ask questions or have much to say, but they know that it's okay to talk about this. It's okay. And children of all ages really can sense that something's going on, whether it's a new diagnosis or it's a change in treatment or there's something else, because things are different. You know, why did somebody drop off a lasagna at the front door? Why are there flowers coming today? Why does mom wear hats now and she didn't used to wear them? Or why are my grown-ups having whispered conversation and I can't quite understand what's going on? And when children don't understand, they try to make sense of their world. So they piece things together and they make up their own stories. And sometimes those stories are more frightening or distressing or confusing than actually what's really going on. So a few points about navigating cancer in the family. So honesty is really important. And that doesn't mean that you have to say everything about everything and lots of details. It just means that you're going to share an age-appropriate version of the truth for right now. Like what are they really going to need to know? What are they going to see? What's going to change that's very concrete? A different babysitter, a different person who picks them up, a change in how you appear. So those are the things that will help them understand. If you tell them in advance, they'll understand a little bit more. Keeping things normal. That can be easier said than done when you've got a lot going on. And I think we know that cancer care can be extremely disruptive. Lots of appointments, lots of new people in your life, lots of things going on. But everybody benefits from routine. So wherever you can continue to keep that going, that can be helpful. Acknowledging uncertainty. In other words, we don't always know the answer to everything. We don't always know what's going to happen next week, but it's okay to just say that. So I wish I knew, but but as soon as I do, I'm going to tell you. You know, I think that's a great question, and I'm not sure myself. I'm going to ask my doctor, and I'll let you know. Expressing feelings, really helpful and not always easy, but really helpful and healthy. So what you're creating is space in which you're dealing with the impact of cancer together. And it helps to reduce that feeling of isolation or aloneness. And sometimes kids are really good problem solvers and they feel included. They can bring up things that maybe you didn't even think about that can be helpful. And it's just we're working through this as a family. Developmental understanding. So what age-appropriate understanding is just the lens through which kids at different ages understand the world around them. And this is how they make sense of things as a 3-year-old or a 10-year-old. Talking about illness isn't just a conversation, one thing about one thing at one time. It's more like many small conversations along the way. And when you're in cancer care for lengthy periods of time, then having these small conversations can really help when you have to maybe have what I call a pivot conversation. And what that means is there's a change in treatment or something unexpected. The babysitter that you had is no longer can do that, so grandma has to come. Or there's something very different in terms of I may have to go into the hospital because I'm going to have some surgery and I have to explain that. And how is that going to have impact on them and their day-to-day? Other changes, but that's that kind of pivot. And if you've been talking about these things, even bits and pieces along the way, then children are more prepared. They're not going to be as surprised. Welcoming all questions. So I use permission here in quotes because sometimes it's really helpful to just put it out there and say, it's a lot to take in, and this is a lot for me too. And sometimes I feel sad, and I have questions for my doctors also. This is affecting everyone in our family. And I want you to know that you can ask me anything that's on your mind. What questions do you have? So as saying, what questions do you have is probably leads to more openness than do you have questions? So, because it's more of an invitation. And then, or what else would you like to know? News bulletins. So those are just brief updates. Sometimes kids smile when you use the term, news bulletins. And it's more just like, oh, I'm going to be going in 3 times next week. I just want you to know, or I'm going to have this procedure. And sometimes that means I feel really, really tired for a couple days. And so I just want to let you know, and I'll talk about it more as I'm going through, but it's a little bit like a heads up. And then because when we as humans get anxious, we sometimes talk a lot. Things just keep coming. So if you have something to say, or maybe it's a little bit hard, or you're wondering about the reaction, just try to help yourself pause and let everybody, it's okay to have a little bit of silence and let everybody take it in. Sometimes less is more. And then it's more just like, okay, I just wanted you all to know that. What questions do you have? So 3 points around ages of children and common things that all kids tend to, in different ways, think about. I want you to know that nothing you did or said caused my cancer. Even older children sometimes worry about this, even if it's not logical. They can sometimes think that they stressed you out. They said some maybe not very nice things back to you, but that nothing they did could cause you to have cancer or to make your cancer worse. Cancer is not an illness that you can catch. It's really more like a broken leg. It's not like a cold, because children, again, even older children can sometimes have thoughts that, because they don't quite understand, might think this. Comfort. All kids, all children, no matter what age they are, need, I think we all need this as people, is a sense of security and want to know what's going on. How is this going to affect me? And who's going to take care of me in a broad sense? Sometimes it means who's going to pay attention to me when there's so much going on. I'm going to go through these slides, which are really about some of the different developmental stages, just to give a little background on how kids perceive and then some ways that you might be able to help. So little babies and toddlers don't understand what's going on around them. They couldn't possibly understand cancer or illness. but they do sense what's happening in their environment. They feel it. And little babies, little ones are wired to be very sensitive to their environment because that's how they grow. That's how their minds grow and their brains grow. But so they can get upset when there's little changes in their routines, but the way that you can help as much as possible is consistency. Consistent caregivers, routines, the same blanket, the same stuffed bear. Some families make little, like a little bed that they take with them, a little bag that has all their favorite things. So wherever they go, even if it's a different place, they have all their favorite stuffies. And then a lot of contact. Kids love, the hugging, the holding, and the soothing is really just helps calm them down and feels good to you too. For the somewhat older kids, 3 to 5 preschoolers, again, can have something called magical thinking, thinking that something they did could cause cancer. And that's because little kids are also very egocentric. They just think about their world. That's all they know. That's how they understand the world. So they think, oh, well, if I kept mommy up all night and she's so tired today, maybe that's why she's sick. Or if I was mad and I thought mommy's so mean and I hate you and I'm, you never help me, or whatever mean thing they say, you put them in timeout, they can then think somehow that made you sick or made you sad. So because of that self-centeredness, they can also keep asking the same question over and over again. And again, just reminding them that I wish I could play now, but I need to rest. And maybe we could sit together and draw some pictures, or whatever other thing that you can do that you can still rest. But just reminding them that you can do that later, or maybe someone else in the family can help out. So watching small children, sometimes parents have said to me, I'm just worried that they're playing with their dolls, or they're putting the bear in their car and zooming it around and saying, we're going to the hospital, we're going to the clinic. And this is just a way, not to be concerned, this is just a way children try to make sense of their world. And then they'll drop that and they'll go on to something else. Reviewing what will change and what will stay the same. Again, so helpful for kids to know this routine, the routine that they may have become very accustomed to is going to change. School age kids, this is a big age group, but so a 6-year-old can be very different from a 12-year-old, but in general, they sometimes can regress a little bit, act younger than usual, maybe even talk baby talk, or sometimes wet the bed. Different things can happen. Be fearful that someone else in the family is going to get sick. And again, because they have this simple way of thinking about things, it is really helpful to ask them how they understand cancer, and also to encourage their questions so that they can share with you the reality of their understanding, and they may have some real gaps. They can ask a lot of questions just out of curiosity because they're trying to understand their world. Why have you lost your hair? Why do you have that bandage? Why do you have that, what's that thing over there? A port or some other device that you might have. And they really just need a simple explanation. Sometimes they get angry and act out because they're frustrated. And again, that idea of stressing you out because they haven't been so great, or things are getting difficult at school, is that nothing they did, life's going on, has made you sick or has made your cancer worse. School is a really critical island of normality, is one way to think of it, is that kids spend so many hours at school, probably more hours than they do anywhere else. And because then they come home and they have dinner, and then maybe they do homework, and then they go to bed. So school is such a critical place for kids to just be themselves. And it's really helpful to encourage them to bring things that might come up at school to you, because sometimes kids, other children, even teachers say things that are confusing or not that helpful, or sometimes scary because they might know someone who had cancer and died, or they ask questions about you as the parent, and or make fun of a child. And it's those sorts of things, hopefully teachers are being tuned into, but also if you encourage them to bring up things with you that might be going on in school, in addition to, what was fun at school today. Bodily complaints, kids at this age can have headaches, stomach aches. So if you hear from the school nurse, or if you ever have worries, just check in with the school, because this is part of their job, is being able to be responsive to you and questions you may have. Teenagers and young adults, of course, they're going to have a much more sophisticated, or they're going to be able to understand much more about cancer and treatment and what kinds of things are happening. And they may have more sophisticated questions. They may also have more worries about life, death. Why did this happen to my family? Why is this happening to me? Worrying about the finances, their younger siblings. They can be very sensitive to the fact that this is going on in their family and how it may set them apart from others. So again, having some space where they're able to talk about some of this, or if not with you, maybe with someone else. So making it okay for them, it's okay if if things come up, you talk with your coach, somebody in your religious community, friends, but sometimes they're not sure about, is it okay? Is it okay to talk with others? It's really hard to protect teens and young adults from the internet and social media. It is just where they live. And so if you can help redirect them to useful, reliable information, whether it's the American Cancer Society or others, I'm happy to share resources with you all. But also to say, there's a lot out there about cancer, and there's a lot of things that are not accurate. They're actually confused. They're just not right. They're wrong. And it can be scary and confusing. Is there anything that you've been wondering about or worrying about, or that you've heard that I'd really like to hear about it? Teens and young adults begun because they're developing in their own way, where it's a lot about them, can feel very self-centered and frustrating because you wish that they could be more helpful and they may not think about how to be more helpful. So it's good to be just very direct and clear about that. And they may not like it, but actually most teens and young adults say it's much better if I just know what's expected. And what are my responsibilities? And what are the limits? So please make sure you're home by 6 so I can get some help with making dinner. Or I need a check-in or a text when school's out. So very clear and direct. And if they haven't followed up, then you follow up with them and just repeat it. And this is how we're going to manage together. And bring them into that, and respecting them as for their age, that they can be helpful in this way. It may seem small to them or frustrating, but it's a big help to you. The interesting thing about teens and young adults, as much as they value and need independence and privacy, is they also want closeness and contact and attention. So they may not ask for it. They may not seem like they remotely are interested in it. But if you can find ways to talk and provide that in whatever way seems right for your child, whether it's you're driving in the car together, you're taking a walk, you're cooking, playing outside, it could be any number of things. So a few points about living with cancer as a family. I think part of what I'm emphasizing here is support over solutions. There is a lot about cancer, living with cancer and cancer care that isn't immediately fixable. We're living with a situation. So, and even saying something like, it can be hard not to be able to control what is happening. And I wish I could make it better, but I'm not able to make it better. Here, what ideas do you have? And what's been on your mind? What can we talk about together, problem solve? Sometimes kids, young adults, of all ages, even a 5-year-old, sometimes has good ideas. Listen to their worries, their needs, their feelings, and validate. So this feeling seen and heard as people, no matter what your age is so important and is part of what helps us feel connected, because we're relational humans. We want to be connected. So it's natural to be upset and it can be hard to talk, but I'm here when you want to, because not everybody wants to talk. Sometimes kids say, okay, mom, thanks, and then they run off. But they know, they heard that it's okay to talk. And maybe they'll bring a question up or they'll let you know what they're thinking about at a different time. Reassure, I wish it were different, and what can we do to make things better? This is a lot to take in, and here is the plan. So this is the both and strategy. So when you say, I wish it were different, I know this is frustrating, and rather than but, say and this is how we can make a plan together. Or what ideas do you have? It's a way of engaging. So keeping lines of communication open. I've done my research work on caregivers of cancer patients, spouses and partners. And one of the things that I learned a lot from those who are helping to support cancer patients is that they're trying to figure out how to be supportive. Is it emotional support? How can I be more supportive that way? Or is it a practical thing? Do I need to get help with logistical things? Do I need to do paperwork? Do I need to help gather information? Do I need to find out more about other resources? Do I need to share questions? So sometimes they're confused and overwhelmed also, and are looking for direction. Like, how can I be helpful? Are we on the same page? So not everybody is always aligned or really thinking about that. So it's good to put it out there. How are you feeling about talking with the kids? What do you think about sharing with the kids' school? Are you telling your boss about my cancer? What should I do about sharing this? Accepting help. Sometimes there's such a need to accept help and figure out what do we really need to ask our friends, family, church community, others for help with, but let's figure this out together. Oops, sorry. So just a couple of other sort of key principles. Honesty. So it can be hard to be direct about things that are sensitive or very emotion laden. I have strong feelings about it. But it does help us to share our thoughts, because again, what you can talk about becomes more manageable. Family members have often said to me, I just don't know what, or if I can ask questions at team meetings or coming into doctor's appointments. So might sit in silence. And something helpful that you can do is to say, can we put a list together? So when we're in the space with our medical oncologist or nurse, we're asking questions that we both have, or I may have that I hadn't shared with you. Acknowledging uncertainty. It's not, sometimes we just don't know the answer to everything, but maybe I can find out. Being patient and giving space, because sometimes in the midst of things that are challenging and hard to talk about, we want to just fix it but sometimes we can't. And it's okay to say, I don't have an answer for that right now. Empathy. So the feeling that I'm trying to understand how you are, not what I think you're going through, but how you are doing. And so empathy and is really the basis for mutual support. And listening to the concerns that you each have, you and your family member, spouse, partner, siblings, about the changing dynamics of illness, because you're in it for the long haul. And so and cancer care is so dynamic. We think we're doing this and now we're shifting gears, different treatment, or something else comes up, or something else comes up in life. Talking about roles and responsibilities is another thing that isn't always made explicit, but it can be really helpful to just say, you know, I used to always do that, but I can't do it now. And now you're doing it. And I'm really glad you're able to take that on for me. Reevaluating priorities. Sometimes you need to sit down and have a conversation about what do we need to stop doing or do less of, or say this is good enough. Even if you're the person who's always gone and done everything at the PTA or in your religious community or whatever that is, or done the big Thanksgiving dinner, maybe this year we're going to delegate that. And getting organized. So how do we share this together? Talking through planning, keeping a calendar, making sure you've got your documents and information, discussing legal and financial issues, things that most people never want to talk about, regardless of having cancer, but really important. Healthcare proxy, wills, advanced directives, all these things that most people don't ever want to talk about, regardless. However, if you do bring up the conversation or just say, we're not having a crisis, it's just these things not only help me as the cancer patient feel better, more relaxed, because I know I've addressed it, but we're planning together, and it can be a gift for others that we've talked this through, and then it isn't something urgent that we have to suddenly address. And also encouraging your family members, partners, spouses, to educate themselves and find their own support, because that's also good for them, just like we all need to find the support that we need. Just briefly, I mentioned that there's what's new at Yale Cancer Center, and Smilow is we're developing a early onset cancer program, which is for patients with any cancer ages 18 through 49. And what we are beginning to do is look at research focused on younger patients, on how they're being cared for. What are some things we can do to better reach out to patients of different ages? And also, how are we engaging with the community in terms of cancer awareness and screening? And just wanted to end with this. I know we don't have time for the breathing exercise, but just want to mention that sometimes focused breathing can be really helpful before you have any kind of conversation or communication, just in general, to help you feel like you've got some more emotional balance. And knowing that cancer is serious business and challenging in many ways. Life is not only cancer. There's, even though it can feel like it at times. So also finding what relaxes you, what inspires you, what makes you laugh, and what gives you peace. So that's all for today. And I'm happy to answer questions while everybody's gathering for lunch. So thank you so much.
much for being here today. Thanks so much for having me. This is my second year here moderating this patient panel, and I'm so honored to be here. I'm really honored to be here because of Sandy. Let's give Sandy a big round of applause. Sandy started off as a work contact for me, but that didn't last for long. We were like BFFs before long, because how can you not be best friends with this woman? She's pure joy. So I'm so honored to be here. It's wonderful to be a part of it again. We're going to have a really interesting discussion here. It's a patient panel. We've had some women just jump in, which is such an amazing thing for you guys to do, to share their stories and to come together and really learn more as we look into the future. So I want each of the four of you, and remember to activate your microphone with the right-hand button there. Let's go down the line, starting at the far end of the table. Please introduce yourselves, your name, and tell us where you're from. Tell us whether you're married, if you have kids, your subtype of breast cancer, and how many treatments you've been on. And lastly, what makes you thrive? And I know that's a lot of things I just asked you to say. So if you forget anything, I'm right here. No worries.
My name is Marlene Gatzak, and let's see, I'm going to start with, I was a breast cancer survivor for 14 years and was recently in January diagnosed with metastatic disease, and I was fortunate enough to come to Yale for treatment this time around, and I have estrogen receptive, HER2 positive breast cancer, which was confirmed this time around through fluid that was around one of my lungs. And I'm currently receiving 2 oral meds, exemestane and ribo. And I'm doing the every 3-month injection, the infusion. And feeling much better than I did initially. Started on a different medication that had a lot of adverse effects for me. So I'm feeling very fortunate to be where I am today and to be here with everyone and sharing my story.
What was your first name again?
Marlene.
Marlene. Just comment on what makes you thrive, or what helps you thrive during this
What
time.
helps me thrive? I guess mostly family and friends.
That's
that are around to support me.
That's a good answer. Thank you. Callie, I believe you're next.
Hi, my name is Callie Thorngate. I from Middletown, Connecticut, and I was diagnosed 4 years ago at 38 with de novo metastatic breast cancer. It was in my liver as well, and it's been found in my vertebrae. I started on Taxol, then I went to Verzenio, which worked for me for 2.5 years. Then I tried Xeloda, which I hated, and now I'm on Enhertu. I also had my ovaries out because what was the point of keeping them at that point? And so that thrust me into menopause like right away. That was fun. And what helps me thrive is I'm a school psychologist at a high school, and I still work full-time, but I'm lucky that my district is super supportive. They let me work from home a day a week for all my paperwork, which anyone who works in public education knows special ed is rife with paperwork. So I get to do all that at home, and I'm probably more efficient than if I were in my office with interruptions all day long. And then I use intermittent FMLA, but I really love going to work, and that helps me feel like there's a significant part of my life that hasn't changed. I do have in a blended family, so I'm remarried, and I have a biological daughter and 2 stepchildren who I'm very close with. And you know, whenever I think anything's hard, it's like, well, I have to be here. I have to see my daughter grow up. So she's 10 right now, and my stepchildren are 12 and 7. And I mean, anybody who's had young children, you don't have time to sit around too much and just dwell on things. So they keep things moving forward.
Thank you. That was great. Corinne?
Hi, everyone. My name is Corinne Blackmer, and I'm professor of English and director of Judaic Studies at Southern Connecticut State University. I'm from Santa Barbara, California, but then moved to Norwalk and was raised by my maternal grandparents. I am married very, very happily so to my wife, who is sitting over here, and we are childless cat ladies.
Woohoo!
But having said that, we are very responsible, particularly my wife, for the raising of my niece and particularly my nephew. The parents are overwhelmed. Would you say that's true, Pilar? I have the estrogen positive, progesterone positive HER2 form of breast cancer. And so far my treatments have been Arimidex and Kisqali. I just know them by their pharmaceutical name, sorry. And what makes me thrive? Several things. My family and my wife are just amazing people, and so positive and wonderful and honest and funny and witty and everything you could want. I'm writing a memoir of my grandmother, so it's creative work as well. She was an abortionist in the days prior to Roe v. Wade, and I was raised by her. She's a truly remarkable woman who was a revolutionary. I have really good medical care, and that helps me thrive as well. And then exercise and diet, I think, are really important for me. Walking. Well, I'm a big walker, and I believe in walking. So that's my story. Thank you.
Thank you.
I'm Linda Freeby from East Granby, Connecticut, about 15 minutes south of the Massachusetts border. I started as HR positive, HER2 negative in 2015, came back triple negative, PD-L1 negative in January 2023, because I kept complaining about aging and a sore shoulder. I was hiking up in the Petra, mountains of Jordan, Petra. And that's how they discovered it, just because I went to the doctor. I've been on Taxol, Trodelvy, and currently on HER2. Let me see, it's my first kind of activity where I join a bigger group. Just normally I'm a hermit in a different way, but what makes me thrive is, well, FYI, I am an orange only cat lady. I have had the only orange cat since I was 4 years old. Yes. What makes me thrive, clearly my husband, Paul, over there, has been to all the appointments, chemo, all the tests. Whether or not he likes it, he learns. We're polar opposites. That's why we really thrive together. I recently retired just so that I could travel. I've been to 84 countries, hoping to hit more than 100.
Wow.
I like learning about anything. So curiosity, being active is what keeps me thriving. And just, being able to do things with friends and family.
That's great. Being curious is one of the keys to life, so I'm glad you brought that up. Marlene, why don't you answer the question first? Tell us a little bit what has been the most helpful between you and your medical team in terms of communicating and giving others some insight.
Compassion, intelligence, and competence.
Okay.
And I have just really had a lot of admiration for the medical team at Smilow, all my doctors, and the ball has thus far not been dropped, as it were. The only thing that happened was they lost my my radiology, my films, when they were giving me the fractions of radiation on my head for a while, and then they reemerged. So I think that the compassion and the humanness of it
was really helpful.
That's great. Marlene, would you answer the same question? What has worked with you in communication with your team?
Sure. I feel, again, compassion was a major theme throughout. And I feel each and every time I have an encounter at Yale, I leave there feeling so positive. The whole team comes in, meets with you, and I take away just such feelings of positivity. And I feel that that probably was the most important thing for me, as I was a transplant from another major city hospital and physician. So I'm happy to be where I am. The travel's a little bit further. However, I feel I made the right decision, and I feel very comfortable with my decision, and the compassion and caring truly comes forward from Yale.
Yeah, good.
And the Smilow team.
That's great. Callie, you mentioned having a 7-year-old, a 10-year-old, and a 12-year-old. Did I get that right? So my question for you is, what is the hardest part of having MBC? So when I heard you say that, I mean, it must be having the energy to keep up, and you're working too. I mean, what in your words is the hardest thing?
Yeah, the fatigue is the biggest part. And that has, ebbed and flowed over the past 4 years. And my daughter especially will be like, Mom, let's go, come on, let's go do this. And having to say, like, I really need to take a nap.
Yeah.
It's hard sometimes, but while divorce is hard, I get to reap the benefit of every other weekend. I get to relax and have that downtime, which I think a lot of parents might dream of sometimes, having a weekend free of children. I try to rest up those weekends, and so that when she is with me, that I have as much energy as possible to give to her. And also like working with my workplace so that I can almost every Wednesday I take off and I just go home and sleep so that I'm charged up for the rest of the weekend, for the rest of the week going into the weekend. But yeah, it's that fatigue part and not feeling like I have that same energy to give, that because we've always been a busy family, being out and about, and I do miss having that energy to keep me going.
Yeah. Thank you for sharing that. Was your name Linda? Why don't you answer the same question, Linda? What for you is the hardest part of living with MBC?
I think my social circle, I had read about it and didn't realize it happens to you in real life. Most people don't understand metastatic MBC. They'll say things like, my friend did this, my uncle did this, So that's, and then you get tired of having to explain to them. So what I found useful is I just find that the core social circle of friends that you don't really have to spend all that energy educating them, because sometimes it's really tiring. And then they mean well, but on the other hand, you kind of have to draw the line. And your real friends are those who are there. So it's actually a test of friendship. Even among relatives, it's your test of who among them can really stand by you.
That's interesting. Thank you for sharing. Why don't we all go down the line and all of you answer my third question here, which is important, I think. What would you like the future of NBC to look like? What would you like to see change? What do you hope is on the horizon? Marlene, do you want to start, or should we come back to you?
Well, I feel, I hope and I pray that continued research on the treatment of MDC and the specific breast cancers that are out there. That's my hope, to prolong and so that MDC becomes more of a chronic type illness, like a diabetes in treatment. That's what I hope for.
I'm forgetting his name from this morning, but the doctor who led the HER2 positive breakout group this morning, he talked about, and my doctor has the same philosophy of starting with the meds that have the least adverse effects. And so in my life, as I'm going through these, I'm always scared that life is just going to get harder. My treatments are going to get harder. So if we can manage treatments that have as few effects as possible, so that we can continue to go out and do things. We can say yes to vacations and travel. We can have the energy to go out with our families and continue to work and feel like we're really contributing, not just to our families, but to our communities, and not feel so isolated in a life that feels really hard. So I would love treatments that are durable, with really manageable side effects.
I really, really hope it becomes a chronic condition, and that one can look forward to having a relatively healthy lifespan. I have plans to go to Paris for 3 months with my wife in 2 years. Really want to be able to enjoy that as much as I possibly can, which I hope is a lot. Dr. Sample, I have to get doctors over in Paris for 3 months. What are they going to do over there? And that the treatments will be less onerous. The ones I'm honored, not at all, but if I have to change them in the future, I don't know. And that there would be really a transformation of this disease to a chronic one would be my major wish.
Linda?
Since I'm triple negative, I'm hoping for more trials and treatments for triple negative. And alongside of that, pretty much the same prioritization as keeping quality of life.
This is just a question sort of off the cuff from the reporter here. You know, Sandy does so much with the Breast Friends Fund to bring people together, to raise awareness around it. Does it help you guys when you come together as a group, when you have peers, when you understand each other? Whoever wants to take that one, jump in.
So I just over this past summer, I don't know if anybody else in the room is familiar with Leslie's Week, but I was gifted a trip for my family to the Dollywood area at Gatlinburg and Pigeon Forge. And that was the first time in my 4 years with NBC that I had kind of stepped into a group of other women with NBC. There were 20 families there, all with children. And to be in a group of people that I didn't have to explain anything. They're like, oh, what treatment are you on? Oh yeah, those side effects suck. And like it was an unspoken kind of connection where you just didn't have to explain this part of your life or pretend it didn't exist for a while. So it kind of encouraged me to say yes to more things like this. And going to another one up at Dana-Farber at the end of this month. And I do feel just a sense of connection, and that lack of having to explain yourself is just a really comfortable place to be.
Thank you for sharing that. I have another question off the cuff that might be a little bit harder. Does it take a real toll on your mental health? And what do you have to do? You did talk about what makes you thrive, but on sort of a day-to-day basis, what do you have to do to keep yourself up?
I'll take that first. People don't believe me, but it has not taken a toll on my mental health. I'm not quite sure why. I think it must have to do with the degree of supportiveness from my friends and family. And my sense that all of us have unique trials and tribulations to face in life. And, this is just one of them. And I have never known a person that didn't have a significant trial and tribulation in their life. So I am quite positive, and I'm not faking that. It's just the way it is. I think everyone I know will attest to that. And I don't feel frightened. Sometimes I'm concerned, but mainly it's for other people in my life. I have a lot of people who depend on me. And so that's my major concern. And fortunately, all my paperwork is in order and has been for years. So that's a good thing.
Does anyone else want to answer that? If you don't, it's okay. We have probably about 5 minutes left, and I'm very impressed with the audio equipment that's here. You all have a mic on your table. Does anyone in the audience have a question? They can press the button to the right side of their mic and ask any of our panelists a question. No? Okay. Why don't, oh.
I think there's one piece of advice you could give a fellow patient that's maybe just starting out. What would you say? Just in 1%.
I think this is advice that hopefully a lot of us have gotten, but take people to appointments with you. Don't go by yourself. There was one appointment that I went to early on that I was like, oh, it's just a quick scan. It's not a big deal. And then I left and I was so upset and didn't expect to be. So take people with you to your appointments, have that extra set of ears. That was more than one sentence.
Since I'm a very practical person, first thing I did, I mean, I like you, stay organized.
Yes.
From appointments to, you know, your legal documents to insurance and everything else, stay organized. And if you can't do it yourself, find a friend or someone who can help you.
I'm going to echo what you just said, because I think it's so, it's my inclination as well to be practical. Keep all of your stuff organized and practical and there, know where everything is, and have a plan. You know, and I think that can reduce anxiety quite a bit. And keep in good communication with other people in your life so they also know, and the people you know and trust. That's very important.
I think for myself, the advice that I would share with others is don't be afraid to ask for help. If you're feeling like you need a little guidance or a little extra support. I have been a very independent woman, and I think that was probably the hardest for me when I had this relapse, is to be able to ask for help or ask for support or let others know that I was in need of support. That's probably it.
Yeah, thank you. Before we wind down, would any of you like to add anything from your own thoughts that we haven't covered? No? Okay. Let's give these amazing women who were so brave a big round of applause. They just jumped in, guys. They jumped in and shared their stories. Really, really impressive. All right, thank you so much. Really great to meet you guys. Thank you so much for having me.
Thank you so much to our panelists who volunteered in the last minute. We are really grateful for you sharing your personal experiences. It's been a really wonderful day. I hope you're all enjoying it. And our last session, we wanted to bring the amazing Dr. Tara Sanf back, who can't say enough about her. She has an incredible energy that surrounds her. And she just has an amazing presentation for you. I won't go into the presentation details because she'll tell you all about it, but I do want to kind of highlight some of the amazing things that Tara Sanf does. She leads a tremendous amount of nationally recognized work on communication, resilience, and wellness. She has been recognized in multiple national forums. She chairs the National Comprehensive Cancer Network Survivorship Panel. She's also the Chief Experience Officer for Yale Cancer Center. And when I'm upset about something, she's one of my go-to people that I go to, and she does all the things that she's talking about and so much more for me. So thank you.
Thank you, everyone. I'm so happy to be here and just really honored to be asked to come back and close out this wonderful day. As Miriam said, I'm going to talk about creating connection in challenging times. I might reference my slides, so I'll try to keep it quick when I look back there. And, you know, I was trying to think, you know, what does this mean, right? I think Corinne asked me right when I came in, I want to know what you mean by challenging times. And so, oh, yeah, let's do that. Well, I don't think we need to go through everything to understand that this is a challenging time. My kids are in the other room coloring right now because they also needed flu shots today and we had no choice but to come together. So I think it's a challenging time. There is this quote, when you Google quotes on challenging times, this guy named Les Brown, he's a motivational speaker. He's been in Congress, really impressive bio, says, we are living in very challenging times. Pressured in the workplace and stressed out at home, people are trying to make sense of their lives. And I thought, how true is that? And then when I looked into it a little bit more, I'm pretty sure he said this in the 90s. So the point being that have we ever lived in a not challenging time, right? And so we can apply this, I hope, to lots of different scenarios. I'm going to try to frame it around healthcare and the connections we make with each other, both as your healthcare professionals and then you as the patients. And a lot of this work comes from this organization called the Academy of Communication in Healthcare. I've done some training with them. I'm in a program to become part of their faculty. And when I learned about this stuff through them, it's really changed the course of my career. And then the other piece of this is positive psychology, which I don't know how many of you have heard of before, but it was founded not that long ago by this Dr. Martin Seligman, who is, I think, at Wharton Business School. And it's the scientific study of human flourishing. So instead of talking about disease and what's wrong with us and trying to get us restored to health, we focus on what's right with us. And, you know, specifically around things like relationships, character strengths, values, all the things we heard about from the panelists that help them thrive. This is just a quick study that I wanted to share. I think these might have been my other slides, but that's okay. This was a study published last year in Supportive Care in Cancer of patients with metastatic breast cancer reimagining care. So just like our panelists led off with what do we hope for in the future, these are 36 patients who were interviewed and said, you know, this is my care now, but what I would like is to reimagine it to include some of these things. So number one is holistic care. And, you know, really having the oncologist see them as a whole person. And to me, if nothing else out of that slide is important, it is that one. But other things include information access and conceptual shifts. So being taken seriously when you're bringing up issues with your healthcare team. I wanted to also show that, you know, nearly 3/4 of patients who are in cancer care, because survivorship starts at diagnosis. These survivorship surveys include everyone, depending on, or regardless of what treatment they're taking. You know, 73% of patients in 2022 were satisfied with their care. But when you asked patients, do you feel your healthcare provider listened to and respected you? Not even half of the patients living with metastatic disease said yes. And do you feel you could always talk to your healthcare provider about your concerns? Half of the patients living with metastatic disease said yes. That means half of the patients in this survey with metastatic disease said, no, I do not feel listened and respected. I do not feel like I can talk about my concerns with my team. So this is what drives me now. And this is what I talk to medical students about and doctors and nurses when I'm teaching communication skills, because I know that there is not a person in healthcare that I've ever met who doesn't care about their patients. So what is the disconnect? What is the challenge? And then this is just another piece of that survey where they ask the patients living with metastatic disease, what are your top concerns? And you can see here that they range from physical to financial to emotional. And so if we as the healthcare team do not also care about these things, that is going to make a challenge. And we're not going to be able to connect. So connection includes caring about what you all care about, not just the control of the disease. So I have a few cases. I'm just going to speak from my perspective. Some of the things that I have found typically challenging, and just talk a little bit about some of the principles that we can use to create connection in this challenging time. So this is a patient of mine who has metastatic breast cancer, and she does not want chemotherapy. This is a few years ago when I meet her. This is the scenario. I have met her. I've heard about her in tumor board. I said, I'll talk to her. And I have this great treatment option for her that, of course, includes chemotherapy. She's a HER2 positive patient, and at that time, we did not have Enhertu, which is a little bit more common now. She doesn't have any symptoms. She has a breast mass. And so where do you start? The challenge is she doesn't want chemo. I want her to take chemo. And, I put this up here to remind me that, she's a human being. She's a photographer. She worked her whole life as a photographer. She's a mom of 2 sons and a grandmother of a granddaughter who she adores and always showed me pictures. And one of her sons, she lost in a tragic accident years ago. But she felt his presence one day in a massage, and she knew he was there. I get emotional. So she really believes in the presence and the aura and all of that. She has a naturopath, she's on supplements. So this is a challenge though. As a doctor, I feel really responsible for her outcomes, and I want her to take treatment, right? And she's not into it. So if we just think about how connection can start with trust and rapport, getting to know who we are as humans, there's this skill that I teach called perspective taking. So if the back of the room was group A, and the front of this room here is group B. Group A, if you look in that hole, what are you gonna see? This shape is a circle, right? And group B, if you look in your side, what are you gonna see? A triangle, right? So who's right? I'll say I see a triangle, and then back of the room say, no, it's a circle, and we go back and forth. So it's a cone. So we're both right and we're both not right at the same time. So we don't know this without taking more perspective, right? And really getting to know, why are you seeing it that way? Tell me what you see. Tell me how you see it. Can I tell you how I see it? So in my perspective, I have the voice of medicine. It's full of science and studies and probably a little bit of medical shame. I don't want you to not do well. I don't want people to wonder, why didn't you give her the most effective treatment, right? We must fight the disease. And her perspective was a voice of the life world. It's her personal, contextualized, lived experience. And when we talk more about it, she had some concerns. And these are some questions that we can ask each other when we're trying to get perspective. They're open-ended questions, but they're more than just tell me more. They're like, ask, what would you fear that might happen if we treated you with chemotherapy? And she felt like she was going to have an allergic reaction. She knew somehow that she was allergic to a yew tree, which our chemotherapy was derived from. And that was the end of the story. And so instead of judging, prove, how do you even know that that's true, right? The perspective is, this is not going to be good for me, and I'm not willing to do it. So we came up with some, middle of the road options, and then we got Enhertu, and she got onto it, and she did amazing for a really long time. So the challenge isn't that she was resistant to treatments. She was not going to take this type of chemotherapy. Okay, so challenging times number 2. This is a patient who has metastatic breast cancer. She's on endocrine therapy and she's having some significant side effects. So we're seeing her quite a bit towards the beginning of her diagnosis. And she's often really angry and hostile. That's kind of the feeling we get. She's tight, she, rolls her eyes a little bit, and she even sometimes curses, like in the room, and occasionally it sort of feels like it's at me. And I need to address this behavior because I'm so uncomfortable. So this is a challenge to me. This is my perspective on this. And so what can we do when we're sensing this anger, right? And what I teach the students is about listening, mostly with silence. And when it's time to talk, trying to request more information or summarize what you're hearing that person say. Let me see if I got this right. What we often do is put up these roadblocks. So when we're listening, we start to give advice, right? Or we start to give a moral judgment. It's your duty to do this, right? Or we hyperanalyze what's going on. These are things that don't really keep the conversation getting deeper. So deeper listening is really understanding how something that someone is talking about is impacting their day-to-day life, what beliefs are influencing this issue, and how is this issue making the person feel? And so we often say anger is the bodyguard to other emotions like fear and sadness. We are really limited with our vocabulary around our emotions. I don't know about you guys, but like when you ask somebody like, how are you doing or how are you feeling? Most of the time, we're feeling busy. Like we give these words that like don't even necessarily mean anything, or we're overwhelmed, or we're just, it's crazy. But like really, truly, how are you feeling? So this is a feelings wheel. There's millions of these online that you can see for free. But I think we need to really do a little bit better, especially with our kids, right? Like of trying to get, boys can only be like mad, really. If they're really saying sad, that's, or something even richer than that. But they can only show their sadness really still as children through anger, oftentimes. So, so with my patient, I had to do a lot of deep listening, and I had to do it by saying, you seem really angry when you're here, and I want this to be a therapeutic relationship. So can you tell me a little bit more about what's happened? And, it turns out that long time ago, she had lost a child at age 3 from a medical complication. And all of this diagnosis, 60 years later, was bringing up all of that for her. And she had felt like when her young son was going into the hospital that she wasn't being taken seriously. They had sent her home and then she had come back and he had passed away. And if I'm totally honest, we had said at a prior visit that we would call her with a result, and we dropped the ball. So now we're adding into that, right? And I would have never known that if she hadn't been able to tell me, and we would have been able to listen deeply to really what's at the heart of her grief and sadness and anger. And she's really afraid of the treatments and what's going to happen next. And ever since that time, we reconnected, and I tried to restore her trust in us and recognize that was a complete mistake on our part, and apologized. I just saw her a few weeks ago. And she's a bus driver, but she's planning to retire and paint because she's been a painter her whole life too. And I just learned that, and it's been years that we've known each other. So this challenging time is able to be repaired, and it keeps getting deeper and richer every time we meet. Challenging time number 3 is a perspective that I have from one of my patients who's also plays in the standardized patient program. Which, by the way, if any of you have that theater bug in you, you're welcome to come to one of the job fairs. And if you're looking for some extra work, it's really helpful to have patients who actually play patients for students to try out their interviews on. It's a safe place for students to learn how to do a medical interview or conversation. So one of my patients does this for me. She's amazing. And she said recently, I'm so much more confident now when I go to the doctor because I understand what the framework is for the visit. So we actually teach that there's sort of a structure to how the beginning, middle, and end of the visit goes. And this is, a screenshot of not my patient, but another role play that I'm doing in front of third-year medical students on how to talk about serious news. And so the question is, I can teach all the medical students this that I can at Yale, but what about the patients? What can the patients be let behind the curtain a little bit? And maybe they'll feel a little more empowered the way my patient does after seeing the content that we're teaching. And a lot of this goes to explaining things in a way that patients understand. So the subtext to every medical visit is this. And I'm talking not about listening and the storytelling part, but the sharing of information. So we are taught as medical providers that when all the information is gathered and you're at the end, you're starting to say in some form, this is what I think. This is what I think we should do. What do you think about that? And I invite you to just reflect on your own experiences. Has that at all been the way it has felt for you? Because sometimes that's the structure, but what is said might be, you have an infection. I'm going to prescribe antibiotics. What pharmacy do you use? Feels like there's a step missing here, right? And so there's an opportunity for patients to learn this and to say, you know what? Actually, I need to better understand why you're recommending this. Or I would like to comment on this recommendation and let you know my thoughts, right? Or wait, I need to think about how this will impact me. Can I talk it out with you? If we signal this to our doctors, they are going to pause back and realize, yes, you're right. I'm following this structure, but now we're on the same page. And so how can we empower patients to gently steer the conversation so that everyone's feeling connected? And this is actually a study from a colleague named Gabby Ciccolini. She's in the area. She works at Quinnipiac, and she runs their standardized patient program. And she actually has launched this program where she trains patients on the medical structure of the visit, not just in cancer care, but in any visit, to get the most out of your medical visit. And I met with her this week. A lot of what she does is to try to help patients understand how to make your best use of that 15 minutes. So this is a screenshot of her website, and she's launching Better Med is the name of her program. And I said, could I talk about this week when we're talking about connecting on challenging times? She said, absolutely. And she said, I would even be willing to do a special session, just for the group that is unified on, in cancer care or in NBC or at Smilow. So this is, to me, a new way to look at communication skills that empowers patients to get the most out of their visits. And there's even, tips and tricks on how to advocate for yourself emotionally and spiritually. And the things that we're not always so good at addressing, how do you make sure that those things are on the table? Okay, now, the last just few minutes, I wanted to talk about this concept of kairos. I've been calling them sacred or transcendent moments, and I was doing this recently, and somebody said, that's actually kairos is what you're talking about. So there's two types of time, chronos and kairos. I didn't know that. But so chronos is what we're always on, right, with our watch and our phones and things. But the kairos definition of time is when time stands still. So these sacred or transcendent moments is a moment that feels set apart from everyday life. A moment that was really real, some people say, or a moment when time stands still. And this sounds like it's got to be a really big deal. And we found that in hospitalized patients, not cancer patients, but in hospitalized patients, a study out of Michigan showed that it often does happen around really serious conversations. Or it could be kind of when it's more relaxed, when you get to know each other a little better and the exam is over, the agenda part of it is over. But it can be as small as an interaction with a stranger. And to me, I think that, that we underappreciate what those are. So those are tiny interactions or glimmers. Glimmers are micro moments of regulation that foster feelings of well-being. And I would invite you to reflect on if you've had any glimmer today. I hope that you have. A glimmer could be as simple as seeing a friendly face, hearing a soothing sound, or noticing something in the environment that brings us a smile. And they're personal to each of us. And a tiny interaction is a glimmer with another person. So a glimmer can also be appreciating the beautiful day, the gorgeous view, this beautiful room, or it can be a tiny interaction with somebody maybe you didn't know very well today and you feel a little connected to them. So how do we keep connecting in a challenging time? Through glimmers and tiny interactions and sacred moments. This is the last thing I'll say. I was on call this past week. It was actually last weekend. I met a patient who is 65 years old. She's not a patient of mine. She's pretty newly diagnosed with metastatic breast cancer, and she was hospitalized for syncope or fainting. She just started on chemo not that long ago, and she was with her fiance, and she went to stand up. She didn't feel very well, and he caught her. And so she didn't hit her head or anything. And I'm seeing her the day after she's admitted. And she jokes that her fiance caught her fall, and he's like, a good catch, literally and figuratively. And so, and she's in her late 60s. So I said, my fiance, like, I wonder, how did you meet your fiance? He does sound like a good catch. And she said, oh, we were childhood sweethearts. And I just tried to be quiet, and I don't know, I had this sense come over me, and I said, really? And she said, yeah. We were childhood sweethearts. We were in love with each other from kindergarten to 5th grade. And then his parents bought a house outside of our school district. I'm gonna get like all flushed talking about this. So they lose connection at 5th grade, 10 years old. 50 years go by. They each get married, and she jokes around multiple times they've been married. They have families, they have careers. And she said, you know what? I never stopped thinking about him. And she said, in the pandemic, I got a new job, and it was 100% remote, and there was only one other person who was hired. And at our orientation, we figured out that that other person knew this man. All these years later, they got connected. They started what is now going to be the rest of their life together. And 3 days after they got engaged, she was diagnosed. And I'm listening to this, and I just feel this time stand still, total moment of awe. And she said, yeah, I always thought about him. And he said he was always thinking about me too. And he came around right when he needed to. And this isn't phasing him at all. He's so supportive. And so, you know, how can we operationalize glimmers in challenging times? It's not easy to be on call for me. So from my perspective, I'm tired, right? I got up early, I had to go see people I don't know. But first we have to be present in the moment. We have to set all that stuff aside and just be with the person who's in front of you. And then, you know, can we use strategies to make positive experiences last longer? So this is what I'm gonna leave you with, is a challenge to savor a moment. Again, my vocabulary has really expanded, and I've really thought a lot more about this since getting into this work. So savoring a moment is intentionally focusing your attention on the positive aspects of the feeling and the experience. So there's a bunch of different ways to do this, and this is just what I will leave you with, and I will challenge you to savor a moment today, this weekend, this week. You can savor moments by feeling pride or basking in something. This is great. I did something good for myself today, right? Or someone said something really positive about me. I'm going to savor that. I'm going to feel proud of that. That's internal. You can give external praise and appreciation and thanksgiving and gratitude. This is so easy. And thank you all for coming today. And thank you for watching and for paying attention and listening at the end of a long day. It's easy to do. You can also savor with experiences. So you can luxuriate with pleasure, really enjoying that hot bath at the end of the long day or that first bite of a really good cheesecake. And then you can marvel or have that savoring experience of awe, losing yourself in the sublime of grandeur, wonder, and the reverence of experience. And that's what my patients give me over and over and over again. And that's why I keep coming back. And now that I have words around it, I show up to be more present every single day. And then I think at the end, what am I grateful for here? And where were my little glimmers? And it doesn't have to be, you know, anything that's so earthquake, right? It's not that rare. There can be little glimmers every single day if we look for them and stay present in the moment. So I'd like to thank you for your attention, and we'll close out the conference.
Thank you so much, Dr. Sam. I'll channel what I learned. I've learned so many things from you, Tara, over the years. But one thing that I took away from last year's conference was when Dr. Sam did a similar talk. She talked about a study where, and this is a paraphrase, she'll do it so much better than me, but there was a study that, you know, if clinicians in an encounter with a patient simply said one simple phrase, that we're in this together, that completely changed the encounter and patients had a much more positive experience. And I took that with me. And it wasn't that I'm just was just saying it without meaning it. I mean, we do really mean it. We're all in this together. And I took that to multiple patient encounters over the last year. And I really saw the transformation of just that one positive statement and how, you know, I saw my patients actually relax in their chair, knowing that I meant and I said what I did. So I will leave you with that, which is that we're in this together. We have your back. And thank you again for being with us today. And thank you again, Sandy.